What I'd like to do is thank you all for coming for the first meeting of this Health and Social Services meeting. We have got quite a few new members on this one this year, so welcome to you, but not just new members, but also new councillors. So welcome to Angela, Paul. We've got Steve back. Well, you're not new though, Steve. You've been here before, but thank you all very much. Before we start, there is some housekeeping rules that we have to do. So there is no expected fire alarm testing today. Therefore, if the fire alarm sounds, please follow the fire and emergency procedures that are applicable to the council house. This meeting will be broadcast live to the internet and will be capable of subsequent repeated viewing. By entering the Warspite room, committee members are consenting to being filmed throughout the meeting and to the use of recordings and webcasting. Can I please ask that you speak clearly and directly into your microphone when addressing the meeting so that online participants and the public can hear, and that it is switched off when you're not using it. Your mobile devices are turned to silent. So, appointment of chair and vice chair for the municipal year 2023-24. For the committee to note the appointment of Councillor Pauline Murphy as chair and Councillor Natalie Harrison as vice chair for the municipal year 2023-24. Have we got to have an agreement on that? Just show of hands. Okay. Obviously Natalie's not here today, so I need to, well, I don't need to, but I'm going to appoint a vice chair, and I'm going to ask Dr. Mahoney if you would like to do that today. Is that okay? Apologies, please, Elliot.
Thank you, Chair. Apologies from Councillor Harrison. Councillor Salmon is substituting today. Apologies from Councillor Stevens. Councillor Tibbetts is substituting today. And apologies from Councillor Finn.
Thank you. Declarations of interest. Any declarations of interest today? Councillor Noble.
I work at Plymouth University Hospitals Trust.
Thank you.
It's other registrable interest, yeah, so we'll take a note.
Terms of reference. Ask the committee to note the terms of reference of the Health and Adult Social Care Overview and Scrutiny Committee. That's pages 1 to 12. Agreed? Everybody agree? Thank you. Minutes of the last committee meeting, need to approve them. Obviously, I don't think there's very many of us that were on this committee last year. There's me, Zoe, I think that's about it, and Will. So, do we approve the minutes from last year? Yeah, thank you very much. There is no urgent business, so we're going to go on to quarterly performance and financial update for Health and Social Care and Risk of Monitoring Report. So we have Rob Soden and Helen Slater to present an update on the quarterly performance and finance status for Health and Social Care. And then we're going to ask Ross to present the risk register as published for the Audit and Governance Committee in March 2023. This will be a report that comes every quarter, so I'm just going to let you know that. Thank you.
Thank you, Chair. This report, which will be produced for scrutiny each quarter, provides a comprehensive overview of some of the key performance and activity metrics that are used by the Council and its partners, including the ICB, Integrated Care Board, and Live Well South West. The report draws on information from the aforementioned organisations as well as University Hospitals Plymouth. The information within it is used operationally and strategically by officers and senior managers across all organisations to ensure the best possible outcomes for people using the health and social care system. I'm going to hand over to Rob Snowden now, who is, as we all know, a wonderful performance advisor for the council, and who will provide you with some of the key headlines from this report. Thank you, Rob.
Thank you, Councillor. Welcome everybody. Thank you for having me today. So there's a lot of information contained within this report, and this serves as only a fraction of the data and information that we have access to via system dashboards that we use operationally. If you do have any questions regarding the data that you want to ask outside of this committee, then please do not hesitate to contact me directly. I won't go through the report line by line so as to leave plenty of time for questions at the end, but I will just give a headline for each section, as I'm conscious that there are new members on the committee, so to give a full overview I think will probably be helpful. I'm sharing it on screen as best I can so hopefully you can all see that. I'm going to start on page 4, and this gives us an overview of demand via the Live Well South West referral service, or the front door. And whilst demand remains slightly or relatively steady, our colleagues at Live Well have been doing a lot of work to reduce waiting lists. And this is evidenced here with both waiting lists for adult social care support and adult social care occupational therapy declining. So I'm just going to scroll down ever so slightly so you can see the two right hand side charts there show the progress that colleagues at Live Well have made with regard to reducing those waiting lists. You have to bear with me while I scroll down. So page 5 looks at outcomes to those referrals. It's important for us as a department and as a system that we have a strong community-based alternative to the long-term care that in place. We know from data that nearly 90% of people who come into social care and receive a referral will not go on to receive long-term adult social care support. And that's why it's important that we have that alternative to that long-term care support in place in the community. Our Caring for Plymouth model aims to support that by providing early support and reducing the need for that long-term care. Page 6 looks at domiciliary care. So domiciliary care, which I'm sure you're all aware, is home, another name for home care, and it's a social care support received in the community. So you receive it at your own home. And what this page does is illustrates our much improved position in relation to the number of people waiting for a domiciliary care package. I'll just scroll down slightly so you can see that bottom chart, and the black line at the top, that's the overall number of people waiting for a social care package in the community, and you can see that we've had a big improvement, and as we've seen numbers in domiciliary care go up, we've seen the waiting list reduced by 77% just from the beginning of January 2023. So between the beginning of the calendar year and the 1st of June, we've seen that reduction of 77%. And on the 1st of June, the number waiting was 23, which historically is a very, very low figure. So that's domiciliary care. I'm just going to give you a headline in regard to reablement. This page tracks our numbers in our Independence at Home reablement service and the associated outcomes to that. On average last year, so that's the financial year 22 to 23, 66% of people left the reablement service with no ongoing needs, which is the most desired outcome of somebody going through that service. So to have 6 or 7 people of every 10 coming out with no ongoing needs is a positive result for us. Page 8. So this is placement and long-term admissions into residential care homes and nursing care homes. We are currently facing a challenge in relation to long-term admissions and placements into residential and nursing care. In 22-23, so the last financial year, the number of admissions of older people, so that's clients aged 65 or over, into nursing care, so long-term admissions into a nursing care home increased by 57%. So that's 41 extra long-term admissions into nursing care. This gives us an indication, that this is an indication of the growing complexity of need that the service is managing. And we are working with partners at the moment to undertake analysis to best understand the drivers behind these increases. So the admissions are going up, and the numbers of people in receipt of that type of care are also going up. We track that weekly. We track all of this weekly actually within the service and respond accordingly once that pressure kind of like shows itself. But that's certainly something that we're responding to at the moment. So on page 9, supported living is another community-based social care package. Like domiciliary care, which I referred to earlier, the numbers of people receiving a supported living package is increasing, and that's the top chart that you can see a very slight increase there. The bottom chart again is reflecting a positive picture with regard to the waiting list. So again, we've seen that come down over the last few months and remains low at the moment. So lots of positive news to talk about in terms of waiting lists for social care packages. Direct payments is on page 10. This tracks our number of people in receipt of a direct payment. You can see that's also increasing. This is positive for us because the more people in receipt of direct payment means that more people are spending their money on the care that they want to receive. We know that historically and currently we benchmark lower than national, regional and peer group averages, but we are improving, and that bottom chart there shows that improvement compared to those benchmarking averages. And I would envisage, if we carry on the trajectory that we are at the moment, that we would be in line with averages, if not above, at some point during this financial year. Page 11 looks at safeguarding outcomes. As you will be aware, safeguarding adults is a key function within the social care system. This page tracks our safeguarding demand, and these are alleged incidents of abuse on adults, but not all of those subject to that abuse or alleged abuse will be in receipt of a social care package. We report this information and a lot more additional information into the quarterly Plymouth Safeguarding Adults Board. This particular page gives us a view on demand, which we can see is holding steady. That's the top left-hand chart. And it also gives us a view as to the number of those that are going on to full investigation. Now that's the top right chart there, and you can see that in 22-23 we saw a big drop. Now that is linked to in-service review of processes. So it's as the service has been working with partners to ensure that the best quality, for want of a better phrase, of safeguarding incident goes through to investigation. And that's why we've seen a drop off in the numbers completed. The chart at the bottom there gives us an idea as to the outcome of safeguarding investigations. And we know that historically we benchmark quite positively in that area. So in 2022-23, 96.9% of people who were subject to abuse and a safeguarding investigation had their making safeguarding personal outcomes achieved partially or fully. And what that is if somebody is subject to an investigation, staff work with them to ensure that what they want to achieve as an end result of the investigation is agreed beforehand. And that's a national policy that we report against.
Can you explain what section 42 is for particularly going areas?
Yeah, so section 42, Gary, did you want
I can do that. So just to help people, for those who aren't familiar here, section 42 is actually one of the sections in the Care Act, and it's the one that relates specifically to safeguarding, and it sets out all of our responsibilities and duties. So when we say we're causing a section 42 inquiry, it means we've seen enough to be concerned, and we're going to go and really look at that, just to try and make sure that the individuals involved are safe, are looked after, and to see if there's anything else that we need to do. So that's when we go and actually go do a formal inquiry to check those things out. Okay.
Thank you, Gary. The next page just gives a bit of an insight into complaints. So complaints can come via three routes. They can either go direct to Live Well South West, who we of course commission to undertake statutory social care work, via the council if that complaint is related to our commissioning function or our retained client function, which includes Independence at Home, our safeguarding teams that we've just referred to, or via the local government ombudsman. Most LGO complaints will have already gone through one of the other two routes prior to reaching LGO level. Overall, the number of complaints is relatively static, but this is again a metric that we track monthly. We include in conversations that we have with Live Well South West. So if any issues regarding themes to complaints or any change in trend that is of concern, then we pick up with those as part of the performance framework and discussions that we hold with Live Well. The next page, this is probably going to be a one-off page in the reports going forward. That's because it's an annual adult social care survey, and this is the first opportunity that we will have had to come to scrutiny with the results of the most recent survey that we undertook in February/March. We have to do it every year. It's a statutory survey that every local authority has to do. It surveys long-term users of social care within the local authority area. Now, we being Plymouth, we consistently outperform similar local authorities as well as national and regional averages for a number of the indicators that are born out of this survey. We have higher satisfaction rates, we have higher feelings of choice and control, but we do underperform against a KPI that measures how easy people find it to access information and advice. So that's been a persistent challenge for us and forms part of our plans going forward to try and improve that. That just gives a flavour of the survey. We'll be doing another one after Christmas, so January, February 2024, and so on. And we track results year on year and benchmark year on year as we go. What page am I on now? So page 14 just gives an overview on support for carers. The number of carers assessments that we undertake fluctuates month on month. I say we, it's Improving Lives Plymouth, which is our commissioned carers function, and they undertake the vast majority of those carers assessments. Since June 2022, the trend has been up, but month on month it does tend to fluctuate a little bit. 400 carers assessments were undertaken last year. We do know, and it's not on here because it's been 18 months since we last undertook it, but we survey adult carers within Plymouth every 2 years. Again, it's a statutory responsibility that we have to do. The last one we did was in the winter of 2021. We will do it again this coming winter. We, as a service and as a department within the organisation, are well aware that we underperform in the outcomes that come out of that survey. There's a lot of work being done within the Carers Commissioning Service to try and improve that. We would hope that when we do the new survey before Christmas, that our outcomes will improve. Page 15 goes into the world of health, which I don't have as much knowledge as I do in social care, but I'll try my best. We're showing a much healthier picture in regard to the number of people delayed at University Hospitals Plymouth. You can see there that we're on an improving trend over the longer term, and the number of the daily average number of delays was 77 during 2022, and between January and May this year that number has dropped to 34. And just to explain what that is, that's people who are fit for discharge at UHP, and Chris will correct me if I'm wrong, I'm sure, who are fit for discharge but have not been discharged effectively. So they're what used to be called a delayed transfer of care. So these are people delayed in hospital for more than 24 hours. But as you can see behind that chart, there is a very faint dotted line, and that illustrates the improved trajectory that we are on. So yeah, an improving position that we have there. The average length of stay has remained relatively static since October 2021, and that's the bottom chart that you can see there. The next page again is hospital data. It gives us an overview of urgent and emergency care. I know within the performance frameworks within ICB and the whole system as a whole, these performance metrics are scrutinised regularly amongst partners. What it's showing is it highlights reductions in the number of hours lost to ambulance handovers, but it is showing that the percentage of ambulances delayed over 15 minutes continues to exceed 80%, and patients waiting for more than 12 hours in ED is above average. These are scrutinised, as I say frequently, among partners. What do's? I did the last page. And the last page reports on planned care and just gives a quick overview of the improving picture at UHP with regard to referral to treatment waiting times. I'm aware that's a lot of information, and I've kind of not gone into too much detail on each page just to almost like set the scene. Please do, obviously we're going to have a period of questions now, but read the report and come to me directly should you have any questions outside regarding the data or the performance outside of the committee. I'm more than happy to respond to you. Happy to try and field any questions that you have now. I'm sure colleagues will help me if required. Thank you.
Thank you. Before we go any further, can I just say, I don't know about other members on this committee today, but I've really struggled with this report because it's so small. It really is small. I can't see dates. It really is small. And even up onto the screen, I can't really see it. So I don't know if, next time maybe we could improve that a little bit. I don't know about anybody else. Has anybody else had a problem? Yeah. Okay. Right.
Yeah, I will take that feedback on board, Chair.
Okay, thank you. Patrick.
Thank you very much indeed, Chair. Thanks, Rob. Obviously, moving to the content, 3 specific questions, if I may, and I'll take them in the order that you sort of presented. In relation to residential and nursing care, against the current numbers receiving care, how does that compare with our base budget for 23-24 in relation to numbers? So that's the first one. The second one, in relation to local government ombudsman, I've never really, even though I've served in Councillor Aspinall's position, ever been made aware of results of local government ombudsman inquiries into complaints. Are there any matters that you're reporting here that should come before members in terms of any policy changes or any specific systems changes? Because I know generally local authorities don't necessarily do what they should do with the local ombudsman. They sort of dismiss it as, well, they make the report and we move on, when actually sometimes the local government ombudsman's view should be taken into account. And the final question, Rob, please, is in relation to improving our communications with the general public. It is an increasing issue that I've experienced from residents in my ward, particularly older people, in relation with their inability to communicate with the local authority. So I am concerned about it, and if you can set out some proposals that you anticipate improving it, it would be welcome, because all we're seeing really is a declining trend of the accessibility of the council, particularly by those who don't use electronic communications. Thank you.
Patrick, the things you were saying about contacting the council and getting through to them, that's something that I'll take through on that ageing well agenda, and certainly I'll be really wanting input from all of you as to some of those useful pointers for that. So I will certainly come back to you on that, and that'll be part of that ageing well, because yes, the way that older people, in fact any person that's digitally challenged or hasn't got access to it, we need to be make sure that, and age is just a number, isn't it? I mean, it's there's a lot more to consider, but certainly that will be coming into that. Okay, but that, although I'll say park it now, it won't be off my agenda.
Thanks. Just on that, thank you, Councillor Aspinall. You know, certainly the council's given assurances in the past that those that aren't digitally enabled can have their home telephone number registered and then their call be accepted. I don't think it's working, so if you can look at that particularly, that would be very grateful.
What I would say on that one as well, councillor, is that we're going through the corporate business planning process, aren't we, at the minute? So the issue around communication is a priority and will be a priority within that, because it's been an ongoing thing that we need to start improving. So it will be included in that business plan. On the question regarding LGO complaints, we do undertake analysis of the number of complaints across the council, so not just social care, and the recommendations that get made by LGO back to us. So we record, we analyse that each year. So to look at trends, are we improving or not? But also to look at how we've responded to those, and that gets fed through corporately into management teams, but also into CMT as well. So we do have a process in place of analysing to best learn from and record what we have put in place to improve those things. So we do that work. To the best of my knowledge, I'm not sure that has come to scrutiny before. And I can pick that up outside with Elliot and Ross to see where best that may come. Can I hand to Gary Reid the
Can you just,
65?
Rob,
Sorry.
can you just actually answer the question? Were there any recommendations on the local ombudsman around systems or policies that members should be aware of?
So there will have been, I'm sure, and we can make you aware of those. I don't know them off the top of my head today, Councillor. Yeah. Gary, can I hand to you read the over 65s?
Hi, Councillor Nicholson. Your first question was around residential and nursing and the numbers including our budget. So I think it's fair to say for us the start of the year has been quicker than we anticipated in terms of numbers. So what we do in all, what I mean by that is we've seen a growth more rapid than we would usually expect. So what we normally do in those situations, which we always get through a social care year, is we just start off a bit of work to kind of scratch underneath that and really be curious about what's driving that. And then we tend to work with our partners to help make sure we understand, are we doing the right thing for people? Are we creating the right outcome for them? Have they gone where they really needed to? And we start asking those kind of questions to see what work we can do. So hopefully that will answer that question.
Okay, thanks, Gary.
Thank you.
Thank you, Chair.
Councillor Ricketts.
Good afternoon. So how many, I just wanted to get a flavour of how many private providers do we work with that deliver domiciliary care in Plymouth?
So Councillor Rickers, can answer that. There are about, I think it was, I say about, and then I'm going to say 99 residential and nursing care homes in the city that we tend to work with, and there are a handful, half a dozen, so 7 or 8 domiciliary care providers that we tend to partner with and work with more closely at the moment. And we always review what we're doing, how we're procuring, and all of those things to try and get best value. And that process is again happening. It happens in the procurement cycles to understand what to do.
So, okay, that's good to know. So about 7 or 8 domiciliary. How does that process work then with procurement? How do we do? Do we review it on an annual basis? Do they come to us?
So in terms of how we go and procure, what we can do to just get some guidance is we can arrange some sessions on our overall procurement in terms of our approach with all those providers and the mechanisms that we use, if that's helpful for you. What we do from an individual person point of view to those people we've got arrangements with is we match them. So we go out to the market when we've got someone who needs care and we talk about them, where they are, what kind of needs they've got, and we have a brokering process that matches people to different providers. So that's the other angle of that from our perspective.
It's just interesting because obviously I'm picking up casework and it's just quite a fascinating situation, and I just wanted to explore it. So you might have a resident who is having really great care with Live Well or something, and then across the road they might be with a private provider which isn't offering maybe the same service, or they're not happy with it, or they could be happy. What I'm saying is there's differences. How would the providers get allocated to individuals? Why would some be with Live Well and some a different private provider? I know it's a bit of a high level question, but
Live Well
must be a formula.
So Live Well provides some crisis response services. They don't really provide any other domiciliary care in the city. So the domiciliary care providers are all independent private providers. What I would say is we do a lot of work with providers to make sure that all the quality of what people get is as good as we can possibly make it. What we know is individual experiences on individual days and care episodes aren't always the ones that we would want for people. So that can be quite variable on individuals' experiences, and you can talk to a number of people who will love a particular carer, love a particular care provider, and someone else won't share that view because of their experiences, unfortunately. But what we do is we have work that goes on in the background around quality, and those providers are of course regulated themselves in terms of what expectations people should have for that.
So I have seen some. Sorry, to the last bit. I've seen some good practice. Yeah, so it's not. I'm not saying it's all bad. I've seen some good practice from Live Well, for instance, and I've seen they leave packs behind for the resident with feedback opportunities, and in most cases the resident's very happy with the care that's being provided. What happens if they're not happy? What would you suggest? And they contact me? What would you suggest that I would do next?
Anyone experiencing an episode of care that they're not happy with should go to the provider from which they're having that support and raise those concerns, and they should do. If they feel not able to do that, they can come forward to the local authority, and some I know will go to councillors as well, and they'll raise them, and we'll make sure those things are looked at. But each individual provider is obliged to receive that. Good ones always want to receive that feedback. They are also obliged to look at that and to respond to individuals. So the advice I would say to give is to always ask them to go back to their provider if they feel comfortable to do that. If not, then they can of course contact us through mechanisms and we'll work on that with them to support them.
Thank you.
Thank you, Councillor Rickers, because this is quite interesting, and I agree. Some people get better care, feel that they might get better care than a different provider. I think maybe it's a suggestion that we maybe look at it at a further notice and put it on the work programme.
It's a fantastic idea. Yeah, I'd be well up for that. Thank you.
Okay. I just want to ask a quick question before we have Councillor Tippett. It's fantastic that the numbers are going down for the dom care and supportive living packages. They're going down. But can you just tell me, I know that they've gone down and they're dropping, but can you tell me how long they're still waiting for? So is it 2 weeks, 3 weeks, 4 weeks, 6 weeks? It doesn't say, it just says that they're going down, but we just still need to know how long that person is waiting for that care.
Thank you, councillor. I don't have the figure here. It is a metric that we capture, and I can certainly, if it's helpful, add it to this going forward. What this report does, it gives a certain view, but there is a lot more data and information that we track operationally and strategically beyond this, and the length of time people wait to get an assessment post discharge from hospital, for example, and how long people are waiting on waiting lists, i.e. average length of wait, longest length of wait, those kind of metrics are information that we hold on our dashboards. I can get that answer for you and send it through if that's helpful.
Yeah, that would be lovely. Thank you very much. Councillor Tippett.
Thank you very much, Chair. My question is about the levels of control among service users. I was really alarmed to see the sudden drop in the response on how if people feel they have as much control over their daily life as they want. And I was wondering if there are any particular plans to address this, as I fear it may get pushed to the side as we're still above the national average.
So that's a really good point and a really good question. You're absolutely right. It has dropped. All of the outcomes that come from the survey get discussed at length within management team, and what you can see there is it's not just 1 year, as you've picked up on, it's 4 years of a decline. We won't just assume that because we're above averages that that's okay. It will be part of planning as we go forward. We are still in the process. We don't know at the minute. All of these benchmarking information is based on the survey previous. So we may actually, when the full results come out in the autumn, we may actually be below those benchmarking things. So we would never rest on our laurels with regard to that. I've mentioned the business planning process that we're going through at the moment. A lot of the things that come out with regard to performance, be them from surveys or waiting lists or safeguarding outcomes, whatever they may be, they get talked about within the planning for the next year. So I would have thought that this will be part of that conversation alongside the issues that we have around information and advice and how people find accessing that difficult. The two are quite possibly linked. So we will take that forward and feedback as we go through the year.
Awesome, thank you very much. I don't have a supplementary.
Thank you, Councillor Tippett. Councillor Mahoney.
Thank you, Chair. And this follows on from your question, really. I mean, it's great, and thanks are due to the Adult Social Care Department for the decreasing numbers over the winter, particularly and into the spring, for people waiting for discharge and the length of time they've waited and the number of people waiting in the community for domiciliary care. So it's a great achievement. Some of this has been achieved with dollops of money that have come down from the government, which have funded things like the health hotel, extra resources at the Venton Centre, extra money for reablement through Live Well, and some money for extra social care packages. Now, we're probably in the best position we've been in since the pandemic, I gather. Hopefully this is sustainable, and how do you see the future, and can we go on funding the things that we need to keep these figures as good as they are and hopefully improve them? I mean, we are doing much better than our neighbours in Cornwall, for example, aren't we?
Shall I take that one? We'll come on later in the agenda to the Better Care Fund, which I think will describe lots of the schemes and things that we've been able to use. We'll tell you a bit more about that fund and how the money works. I think, yes, we're really pleased with our position, John, and how we've got there. In fact, we've worked hard to try to exit some of the schemes that we've put in place through the winter, so we can go back and return to a business as usual model, which I think is really quite important for us. But we've been lucky to run the schemes that we have, and they've really helped us. In the background to that, and you'll see some other information today, we'll talk about workforce, which has been really important for us, and it's been a factor over the last year or two in terms of how we've really struggled. That's also showed signs of recovery. Now, we don't know if that's going to stick yet, and I think that will be really important, because if we can, through the workforce of the people in this city, look after the people we've got, then that will put us in a much healthier position and puts us in a place where we're better able, particularly financially as well as through workforce, to sustain that kind of that improvement, which is what we would hope to do, but we don't know for sure.
Thank you, thank you.
Councillor Riley?
Thank you, Rob. I'm not really good with graphs, so it was a really good explanation. I just wondered how is it assessed, the waiting list for domiciliary care? So is it risk based, and how do we maintain the dignity of those waiting?
So I'm not a commissioner, so I'm not going to give you the exact response. What I would say is that they rag rate waiters, red being those most in urgent need of support, obviously. So there is a priority approach to it. I don't know, Gary, if there's anything else you want to add to that, but that's it.
Yeah, hi, Councillor Ryan. So the process, and we actually had to enhance this process through the last few years, but as Rob quite rightly says, we rag rate everything that comes in. So once you've had your care assessment and we understand what your needs are, and if you need domiciliary care, you'll come with a priority as well to help make sure we give the care we've got to the people who most need it first. So I'll give you just an example of that, very simply. So if, for example, you lived at home alone, weren't able to maybe always advocate for yourself or raise alarms or very on your feet, you'd be a much higher priority than someone who lived with family, who could do all of those things, if that makes sense. And that's the way that we try to guide that. What we also do is we go back around that process every now and then to check that people's positions have stayed the same, because life evolves and things change for people. So when at the height of it, when we had unfortunately quite a lot of people waiting, we had processes that at time to time dipped back and checked how are you doing, how are things going, just to make sure people were being looked after that we needed to.
Okay, just a quick one. What measures are being put in place up at emergency or E&D to reduce the waiting times? I know it's still above average, so what measures are being put in place to try and reduce that even more?
Thank you. Yes, so that's a really good question. Certainly in terms of the data that Rob shared, we remain in a really challenged position within the city. So despite those real great improvements that have been made from a discharge perspective, that position around waits, both the ambulance within an ED department are really challenged. There is a whole raft of work that's being undertaken around that. We've got quite a lot of support and oversight from NHS England at a national level with the national team undertaking some work currently to understand what some of the drivers behind that are, so that we can make sure that the actions that we're undertaking are targeted specifically to help to address some of that. And we do have some positives within the city. So whereas other areas have seen significant growth in terms of the number of people arriving at the emergency department, actually it stayed pretty static within Plymouth. The challenge that we have is then how we flow people through the hospital and recognising some of the constraints we have from a bed basis within the city. So there's a lot of work as well at thinking about actually the level of need that those individuals that have got the time of day that they come in, and where we can undertake programmes of work to work with communities and others in order to make sure that we're identifying those individuals and supporting them in a different way so that they don't need to necessarily come into ED. But in terms of, so that kind of broader piece of work and how we bring that graph down from the line that's on there, that's our kind of top priority at the minute within the city. So we recognise that that's, from a health perspective, is a real challenge that we have.
Has anybody else got any more questions for Rob or Helen? Councillor Ricketts?
I just wanted to say, I think it's an outstanding report. That's what I'm saying. It's a fine art obviously been off the council for a few years. It's a fine art putting these performance reports together. I know the writing is a little bit small, but that's kind of a little thing. But generally, it's an outstanding report, and you can read it quickly and get a real feeling for what's going on. So I just wanted that noted, really.
Councillor Ricketts. We're going to hear from Ross now.
If you really want to hear from me now, Chair, that's no problem at all. But there is a finance report on this paper, and Helen is here to talk to it.
Sorry, Helen.
So hopefully this report is pretty self-explanatory, but I will take you through it now up on the screen. So it takes you through the outturn, financial outturn for 22-23 and the budget for 23-24 and how we've set that. So you can see the adult social care budget for 22-23 was 85 or just over 85 million, which is by far the biggest revenue budget within the council. And the final outturn was 83.222 million. So that gave us a large underspend last year, which was required to meet pressures within community connections, and those are homelessness pressures and emergency accommodation for homeless people. The first table there, it takes you through the last, I think, 8 years and showing that the ASC budget has come in, the outturn has come close to budget for each year, except last year where we had that additional underspend to help homelessness. So this next table shows you where we did have some pressures within 22-23, but these were then offset. The table shows you individual care packages, budget and outturn. You can see that dom care and direct payments were our biggest pressure areas, but we were able to offset those with increased client and joint funding income. So as packages grow, we also get increased income from clients and the NHS where applicable. And we also had additional grant funding in year, which allowed us to report an underspend. So for 23-24, the Directorate was given a budget uplift of 7.582 million. So that's when we've modelled what we expect the demand to be through the two main drivers, which are the national living wage, which went up quite a jump in 23-24 to £10.42, and also inflationary increases. So we've modelled the expected pressure from those, and that's what was factored into the MTFP and budget workings. But on top of that, we had additional delivery plan saving targets of 3.712 million. So our actual net budget increase was just 3.870. Oh, sorry. So this next table breaks down our delivery plan saving targets for 23-24. The two biggest ones are mostly to do with managing demand across the care provider market and ASC packages reviews. So we have budget containment group where we've targets and plans for those Live Well are undertaking package reviews. We're also expecting to get additional income through direct payment clawbacks, which will meet some of the delivery plan targets. And also reduce cost of transitions where children are becoming 18 and moving from being looked after children to coming into adult social care where applicable. There's also some targets for reablement, contract delivery savings and staffing savings. There's also some contract savings at the bottom there which actually do belong to public health, so but they have already been met. So the next sheet shows how the 23-24 budget is broken down. So the top section is all the care packages, and the care package expenditure is by far the highest. It's over, I think, 103 million. The most expensive one, usually we group them together, is res and nursing, so that's over 50 million. Then supported living at 26.551 million, dom care's 13 million, direct payments 12, and then the smaller package types of extra care housing and daycare. We also have own provision budget, so this is mostly staffing costs. This is for Colwyn Lodge, fines, independence at home, the reablement team and the
retained client function. We also have other staffing in the directorate, mostly commissioning and the safeguarding team. We've got the management and also transformation, and those costs of those budgets are split out there. Contracts, our main contract is with Live Well for the delivery of the social care, so that's nearly £7.6 million budget for that. The next line is all other contracts. Now this is actually netted off by health income and income from other departments, which is shown further down, but these are the contracts with things like Alliance, Plymouth Guild, Citizens Advice Bureau, Domestic Abuse Sanctuary Contract, and those sorts of things, which we can provide a breakdown outside here if needed. We also have the equipment contract. So this used to be CS Community Equipment Store, but there's a new provider this year. So that's a net budget of 1.540 million for that. And then there's a line for other management costs, but that's basically everything else that's not in those other lines. It includes contribution to out-of-hours service, legal costs, and where we transfer some of our BCF funding that we receive to the NHS for their service. Now the bottom section offsets some of those costs higher up, especially the CREG fairer charging and direct payment income is all types of client income, which offsets in part package costs, as does the joint funding where a package has health needs, then we will receive funding from the ICB and the NHS for that. I've been asked to explain what CRAG is, but I can never remember what the... Gary, did you want to? I never remember what the acronym is. I'm new, sorry.
I feel like I'm being tested. But so CRAG is the nationally set charging framework for people in residential and nursing care. So that what that does is it tells the authority how it needs to go about financially assessing people where their long-term need is met in residential or nursing care, and it gives you all the criteria for working that out. It tells you what money you need to leave people with, and all those things. So that's called CRAG. What you then have is the fairer charging, which is if you're receiving domiciliary care, for example, in care at home, then you use the fairer charging process, and that can be a little bit more locally set, and there are some things that you can make decisions on including or not including in the financial assessment. Okay.
So this line here for health income, so some of this is the funding that goes against some contracts. Also, it's where with BCF and IBCF, some goes to the NHS, some goes to us, and then we kind of move it around as we work jointly to sit in the right place. So that's some of that income there. We've got government grant funding and other income. This is mainly internal recharges. So again, where we've got contracts that say public health contribute to, this is the income for that moving around to departments. There's a line there for delivery plans, which we went through further up, 3.712 million. And then as we balance the budget, we have the line 5.606 million, which is where we've had savings targets in previous years that haven't resulted in a permanent budget reduction. So as the budgets are built on the prior year budget, that is baked in, but we do have plans to offset all that of the whole 5.6. That allows us to balance the budget, and that brings you to the total net budget of 88.859 for 23-24. I'm happy to take any questions.
Thank you, Helen. Councillor Nicholson.
Thank you very much indeed, Chair, and thanks, Helen, for the report. Obviously, I think the department should be congratulated in the outturn position for 22-23 being within the budget, because it is a challenging environment, you know, knowing what the officers particularly do on a day-to-day basis is challenging sort of every day of the financial year. So well done, Gary, and please convey congratulations to the team. Having said that, an underspend of 1.8 million is quite significant, and the question I have is more probably for Councillor Aspinall rather than Helen. The report that BBC had on Local Spotlight only a couple of days ago regarding the current fees charged by the residential care sector in Devon clearly shows Plymouth significantly lower than other Devon local authorities. When can we expect, what can we expect in terms of an uplift to residential care and fees in Plymouth to safeguard the current market in the city and not be in a position where we are perhaps in in children's services, where we rely on outer city placements costing far higher because we've effectively destroyed the market within the city. And given inflation is still 8-9%, politicians have got to recognise that costs in the private sector are as bad as the public sector. And given the fact that we've now set the council budget, can we expect an increase to be announced in the near future, please, Councillor Aspinall? Thank you.
My understanding is that there's been an 8% uplift in that budget already this year, and that was done recently. And certainly, historically, Plymouth has always had slightly lower amounts, but that's because of the various types of organisations we've got, isn't it? And the people we contract with. Gary may well be able to give you a bit more detail than that, but that's my understanding. There's definitely been an 8% upright, and in fact, that was reported to the BBC a few weeks ago when they ran that. Gary, sorry to dump you.
That's okay. So I think you're right. We did do an 8%, 8.5%. Thank you, Helen, uplift for last year, and that's been part of the work done. There was some national programme work done where we were asked to look at what people felt were fair costs for care in various places, and he gave you different ways to try and help understand that. So 8.5% was our move for last year, and we'll be looking at what comes down for next year, because we've also received money to help look at pay awards moving forward. We have to be slightly careful sometimes when we compare our rates with particularly our neighbouring authorities, because the geography is different and the locations are different, and therefore the pricings can be different. So that's not to suggest in any way that we don't want to do as much as we can possibly do to support our market, but our job is twofold. We have to make our money go around, but we have to have, I'm just giving a slight note of caution in comparing like for like rates. We do have comparator authorities, but they aren't our direct neighbours. So that's the only thing I would add. Councillor Nicholson.
Yeah, thank you very much to Councillor Aspinall and Mr Wallbridge for the response. A bit of lesson learned from when I was the Cabinet member is that we tend to uprate at the end of the financial year rather than at the beginning of the financial year. So the increase you're talking about was the tail end of the last financial year, and we tend to hold money, certainly my experience having been the Cabinet member, perhaps longer than we should. All I would urge through you, Chair, to the Cabinet member is that given the fact that there are homes closing in Plymouth, on a periodic basis, and those places are lost and causing pressure to the system, could we not perhaps look at our budget for this year and, if necessary, uprate earlier in the financial year rather than waiting until the end, and therefore safeguarding places that clearly will be needed as we see an ageing population? Thanks, Chair.
Okay, thank you, Councillor Nicholson. Thank you, Helen. Ross.
Thank you, Chair. Members, I'm not going to put my report on the screen. It's in your pack. Hopefully you've all had time to read it. So this risk report, along with your performance and finance reports, are here to help you set your work programme in over the coming year to enable you to deliberate. This risk report you have in front of you is the most recent risk report. It's slightly out of date, went to Audit and Governance in March. We're currently preparing the new risk report to go to Audit and Governance at the end of this month. It covers the strategic risks facing the council, and currently there are 22 strategic risks on our corporate register. 6 of those are red. There is a single red risk which falls within the remit of this committee and is referenced the lack of adult social care workforce and growing fragility in the adult social care market, reflective of some of the conversations you already had today. Now, I think Gary would describe an improving picture in terms of the adult social care workforce, but of course this is a symptom being felt across the health workforce also. But having had a look at some of their workforce, it does look as though there's improvements there. It does look, for example, like Derriford is getting back to plan in terms of its recruitment, which is good news. There will be further updates towards the end of this month, and Gary will be able to provide those. That's the red risk. There are a number of amber risks on the report. Risk number 8 on page 60 refers to health inequalities. an ongoing issue that we've faced as a council for many years. What I would suggest to members is that you take a read of the Plymouth report, which fulfills our requirement for a joint strategic needs assessment. That will be considered at Health and Wellbeing Board on Thursday, so the papers are published. But from there, you will see that life expectancy, which acts as a pretty good proxy measure for health inequalities, still shows significant inequalities across the city. So east of the city, life expectancy is around 85 years. As you move closer to the centre and the west of the city, it drops by about 7 years. So that's certainly a risk that the committee may wish to further look into over the course of the year. Risk number 9 refers to budget pressures, as we've discussed. No doubt that will need to change given the outturn. And the risk number 10 refers to changes or adult social care reforms. This committee has been diligent in looking at those over the last 12 months and would expect that to continue. Chair, that's the extent of my presentation. Happy to take questions where required, but of course this is to help guide your work programme for the course of the year. Thank you, Chair.
Thank you, Ross. Okay, I'm going to move on because we can put it on our work. We can have a look at these and see what we want to put on our work programme. So we're going to go now to no right to reside. So it's Gary.
Okay, thank you, Councillor Murphy. I think there's been a standing item here where I know Anna, who would have been here previously, will have talked to you, just to give you a very brief verbal update on the current position of the no criteria to reside. So I'm happy to just do that for you. So the position as of today is that Plymouth remains at 5%, Devon is at 5%, and Cornwall are at 10%. And just for information, the target is also 5%. So Plymouth are performing really well in this area at the moment, and we've seen that the numbers can fluctuate pretty much throughout different weeks, but the numbers have been like that for a little while now and a few days, so we're quite pleased with that. Importantly, for our patch in our area and for our acute trust as well, that we've also seen that position improve for Cornwall. So 10% is an improved position. So again, that's really good news. Our focus now really is just on sustaining that work, and I think the presentation that Chris, and I'll do just an introduction what Chris will give you around the BCF will show you a bit more on that. The last thing I would say is Plymouth at the moment for the Southwest is the second best performing system in terms of its no criteria to reside. So at the moment we're really pleased. We haven't always been there, so we're going to enjoy that moment while we are there in terms of supporting our colleagues.
There you go. Can you just explain to the new members that are on this committee what no right to reside is, please?
Yeah, so it's a term. It's not one that we have made up. It is one that is given nationally. So no criteria to reside essentially means you no longer need to be in a hospital setting and in a hospital bed, and that's the figures that they use. That's the terms that they use for those individuals. So it used to be delayed discharges and all these things, but the narrative has changed. So that's what that means for me.
Gary, can you just carry on with the Better Care Fund, because obviously Anna's not here, so I know you're standing in for Anna, so that would be great. Thank you.
We are. I am, but I also welcome Chris. So Chris is our Devon ICB representative and knows much more about this than I do. But what I thought I'd do is just give you a little bit of an introduction to the Better Care Fund, just for people who don't maybe aren't familiar, and then I'll hand over to Chris after a couple of slides for him to tell you a little bit more. So we've just put a little bit of information up for you. So the Better Care Fund, it's the only mandatory framework to facilitate integration between health and social care. And I think what that means is really the BCF, it provides money, but it gives some of it to the NHS and it gives some of it to the local authorities. And it says work together on some shared objectives. And those shared objectives are listed up here for you as well. And my screen has just covered them off. But around improving discharges, reducing pressures on urgent and emergency care, supporting social care to achieve those goals, as well as supporting intermediate care, unpaid carers and housing adaptations, all with that view of trying to support that flow out. So it's a really important framework, and it's been with us for a good few years. And what we'll do in a moment, we'll take you through a little bit more of that. And really the core objectives, I think we've listed up there: enabling people to stay well, stay safe, stay independent, and stay at home, which is really, really important, and to provide the right care in the right place at the right time. So that's the thrust of what the BCF tries to do. When you get money from the government, it also asks some things of you, and it gives us those requirements, and it sets those out in some documents for us. It tells us the sorts of things that we need to do to so every year we'll put together a plan for BCF that goes forward. That will go forward to NHS England. They'll need to look at that and agree that that's a good plan for us. That's a really important step, and it's a step we also need because that plan needs to go in and through the Health and Wellbeing Board, which is the accountable governance, which will show you a chart there, which we have to get signed by the 31st of October. So we put the plans in, you go through this dialogue with people, and then you get that agreement, and then that leads into the Health and Wellbeing Boards as well in terms of being cited and monitor around that. And I think what I'll do is I'll hand over to Chris, and what he can do is take you through the rest of the slides. If you nod, Chris, when you need, and I shall move them forward for you.
Brilliant. Thanks, Gary. So next slide, obviously this just talks a little bit about how we use the Better Care Fund within Plymouth. So it's something that's been in place for several years now in terms of the statutory framework and that transfer of money. What we've done locally is invested in long-term services. So as Gary described in terms of the aims of it, it's very much about how we support individuals to remain at home by investing in community services that wrap around them. And we recognise that in order to do that, that takes a long-term commitment. And alongside that, there are components I'll work through the details a little bit. I'll give an overview of the details that support some of our investment into the care sector, how we make arrangements in terms of the voluntary and community sector within the city as well, and how we work as partners in order to support individuals. The investments themselves absolutely align to those key planning requirements that are set out within the document, and a big thrust of that in terms of the discharge activity too. So Councillor Mahoney earlier mentioned the investments that have taken place over recent years in terms of the supporting system flow and reducing our delayed discharge position. The Better Care Fund enables us and offers us a platform to think about how we invest in some of those things on a longer term basis. So what we are doing, although we've got that commitment in terms of the investments that we've made on a ongoing basis, and our plan this year is to roll forwards those schemes that we'd put in place over previous years through the Better Care Fund. What we will be doing is undertaking an evaluation of those schemes over the next year to look at actually, are they delivering absolutely what we need them to do, and are they having the impact that we want, in order to consider, do those continue, do we need to look again and perhaps refocus some of that investment in order to maximise the effect that it's having. So to help guide us in that, there are a set of 5 key metrics that are determined by the National Planning Guidance. So they're there on the screen in terms of how we're working to wrap around people to avoid admission, identify individuals and avoid admissions, how we're responding particularly to individuals who fall, and ensure that we can support them so that if it isn't necessary for them to go into hospital, that we can support them within their own home. How we can make sure that people are being discharged primarily back to home if they have been into hospital. I know Rob, in terms of earlier on in his overview around the performance measures, obviously that's an area of focus that we've got at the moment, along with that focus around residential admissions and some of the uptick that we've have seen in there. And our reablement approach in order to respond to those individuals who've either had a crisis at home or a hospital admission, in order to support them to return as best they can to the levels of need that they had previously. So we're looking in terms of the plan that we've putting forwards at the moment, that describes our proposed trajectories around those metrics, and we're really keen to be ambitious but realistic in terms of, we know there's increasing demand that we face for services within health and social care. So actually, how do we make sure that at the very least we kind of baseline and maintain the position that we're doing over the next year, and then think about actually what those are the things that we can invest in to support people to bring that down further. So then the other thing to reference is the additional discharge fund. So this was nationally announced money last year. So it's £600 million that's been given nationally to ICBs, the NHS and local authorities for the current financial year. And also looking forward to next year, that fund increases to £1 billion. So it's extra money that we know we've got coming to the city to support us around growing capacity to support individuals being discharged from hospital. As part of our Better Care Fund planning this year, we've had to describe how we're going to replace that moving forwards. So there are some rules around how we best use it. We can't replace existing services that we've got. We need to be able to demonstrate the additional capacity that we're bringing into that. The funding allocation for Plymouth, so how that £600 million translates to Plymouth, is 3.3 million in total, and that's split 1.81 million coming to Plymouth City Council and 1.5 million coming to the Plymouth locality of the ICB. So what we've done with that, in the same way that we approach our Better Care Fund money, is pull that together and agree jointly how we can best utilise that to maximise the impact. And we're very committed, so we've already got some things in place in terms of increasing capacity and recognising that that's reflected in the numbers that Rob shared earlier, but also thinking about actually how can we use that money to support more people at home rather than necessarily bedded options on discharge, recognising the potential impact that has in terms of long-term need and improving outcomes for individuals. So it's really positive in terms of giving us an opportunity at this point in time where we're performing better in terms of our criteria to reside position, to actually think how do we want to use that as a bit of an enabler to work in a different way and improve outcomes for individuals on discharge. And positive as well that we know that's there for a couple of years. So often this money comes out very short notice, very short window, very specific things we're allowed to spend it on, but this is giving us a bit more flexibility to do something a bit more transformative. So the governance details, Gary described. The BCF itself sits under the Health and Wellbeing Board, and there's a requirement for both the Health and Wellbeing Board and the ICB to sign off the proposals and the plans that we're putting in place. And then the BCF oversees and receive quarterly updates in terms of the returns that we're making, our delivery against those metrics. Sitting beneath that, we've got a planning group that brings together officers from the ICB and the local authority in order to oversee those schemes that we've got in place. Alongside that, there's a kind of a parallel reporting line up into the local care partnership executive leadership group. So we really recognise the role the Better Care Fund offers in terms of that partnership approach and how we're addressing those priority areas that have been identified as part of the plan. So we continue to provide updates through there to show how we're utilising that money as well. So these next couple of slides just break down some detail in terms of how that investment is being spent. There are some very detailed spreadsheets and a 40-page document that describe this in very in-depth. Thought it probably wasn't best to take through line by line of that today, but just we've grouped some of these together to give a bit of a flavour of what the investments are. So the total pot is 37.8 million, so it's quite a significant investment that we're describing. There are some mandated components of that we have to fund through the Better Care Fund, and a formula as to how those are determined. So one of those is the community equipment service. So that supports people who need equipment within the community, either be it on discharge or at home. So there's funding to support that in the contract that we have in place around that. The build facilities grant, so those improvements for individuals who need those at home, so that's supported there. There's also a line which is around support to social care and delivery of the Care Act responsibilities. So there's obviously some of 6 million that's associated to that, although you'll see in some of the other schemes we're talking about in a minute, there's some other overlap in terms of other investments that support some of those pressures too. Hospital discharge, so this picks up a big component of the activity in terms of what we've got. So there's some investment there around the independence at home service and the hospital facing support of that. There's the commissioning of placements with enhanced support. So things like the short-term care centre, the William Patricia Venture Centre in Plymouth, really good model in terms of outputs that we're seeing for helping people to re-able and step down once they leave hospital. So there's funding associated within that, along with some other services that we're purchasing within that line there. There's the trusted assessor model, so how we're matching and supporting people to be identified what their need is and get them into the right place when they are discharged. And a bigger figure there, which is about our total delivery service, the beds that we're buying for people on discharge in care homes across the city, how we're assessing and reviewing those people and some of the rehab and reablement support that they get in order to then return home afterwards. And also associated with that is the command centre within the hospital, so that joint work across UHP, Live Well, PCC and the ICB in terms of bringing together that data analysis and the understanding to help inform and track support for individuals. There's also then a component that's around admission avoidance, so what those short-term support offers that we can put in place for people who are at home, need some support with a wraparound multidisciplinary team in order to help them recover if they have a crisis that means they don't need to go into hospital. So some short-term placements and wraparound support with that. And also a really good model that we've got in terms of the frailty nurses. So those are nurses that are sat in the front door of the emergency department at Derriford, but they outreach to the community as well in order to identify individuals who could be supported in different ways within the community rather than necessarily being admitted into hospital. The care market aspect, so there's some of the additional investment that we've been able to secure to support investment pay rates to improve the resilience around domiciliary care. Some of that's legacy stuff that we've in prior years put in order to help grow and sustain the market. Some activity in terms of primary care support as well, so where we're buying beds, making sure that we've got dedicated offer to help some of those individuals, and also some investment in terms of growing quality improvements within care homes too through the Quake team. And then there's a whole raft of other investments, so there's like a couple of £1 million that go into the carer service, and that covers a range of things across carers' personal budgets, identifying carers, working alongside primary care to identify carers too, and raise the profile of and support carers within the city, because we know what a valuable job they do. Health navigators in terms of some of the work that we've got around teams who help identify people through pathways, the crisis cafe as well, and the community crisis response service, both again coming back to kind of that admission avoidance, actually where people have got a crisis, is there different models and different support arrangements that we can put in place. The other line on there in terms of the VCSE as well, so there's a range of different schemes that we work with different VCSE partners across the city. To give you an example, we've done a lot of work with Age UK over the winter in terms of setting up a discharge support scheme. So they've got funding to support up to 40 people a month. And what they do is where people are identified that don't necessarily need a reablement package or a domiciliary care package, but they just need somebody to go with them when they go home and support them for a few weeks afterwards, help them with benefit applications. There needs to be a deep clean of the house, helping to arrange that, shopping, accessing prescriptions, coming back in for appointments. That's been really successful in terms of helping a number of individuals. We've got a number of case studies that demonstrate the value that that's had and the really real positive impact it's had for residents of Plymouth who otherwise were at risk of bouncing back into hospital because of a lack of support or having to use other services that we've therefore been able to release. So just offer that as one example. There are several, but those are the kinds of things that we're really keen to make sure that we've evaluated and consider how we bring those in moving forwards. And also the last line on there, I mentioned earlier around the additional discharge funding. So we've been undertaking some detailed analysis to understand what our gaps are and what the kinds of schemes that we can put into. So very much shifting that focus though to how can we support more people at home on discharge, recognising that we've got more that we need, more that we can do in that space to help reduce the number of people who are going into residential settings on discharge. So that's it in terms of the overview today, but very happy to take any questions, myself and Gary.
Thank you, Chris. Has anybody got any questions? Councillor Noble.
So you have the funding, you're almost looking at the journey a patient goes through, but obviously the patient goes through different parts of the health service that are different organisations, like a kebab that's kind of joined up. And so is the focus of the better care funding, the extra money, perhaps, is that focused on managing the constraints, you know, where there's those bottlenecks or pinch points in that pathway, or how's the approach based, or is it based on you know, the functions or the silos of the hospital, the GP, the home care, what have you?
Thank you, Councillor. So both really. So we've done quite a lot of work in terms of using so there's a national tool that's recently been released that was produced by Exeter University and Bath University, and that's enabled us to put in the number of people who are in hospital and being discharged each month, and undertake some analysis to say, actually, if our length of stay and the amount of care that we've got is X, how many people would we be able to support, and how can we shift some of that in order to make sure that we're getting people into the right place in line with best practice. So that's helping inform an understanding of actually what's the care, what's the arrangement that we need to put in place. The other component, as you say, it's a very complex system, isn't it, to navigate, and some of the short-term nature of the investments that we've had previously have meant that we've had to set up lots and lots of different services that respond to need and absolutely help, but we create lots and lots of lanes on the motorway. So when people are being discharged, when the teams are discharging people, it makes it quite complex, or for community services as well, and as you described, to map in and identify the best support offer. So we are looking at how we can simplify and bring some of that together. There's a big programme of work called the Discharge to Assess Improvement Programme, so that's being led between the ICB, Plymouth City Council, Livewell and UHP, and it's absolutely looking about how do we streamline some of that and make sure that we've got the right practice, the right wraparound support for those individuals to get them into the right place and get the best outcome. So a bit of both, really.
Do you look at sort of vertically integrating some of the, you know, whether there might be something that could be separated or brought together to make that, is that something that's looked at? And that would be perhaps to do with the various stages that people, the various services and organisations people move through. You know, maybe something going from one organisation and becoming another, the next step of the process, or maybe, you know, one organisation is taking that the next step of the process into their organisation, if you know what I mean. Is that looked at, or is that not covered?
So it absolutely does in terms of the Better Care Fund looks at, and one of the driving intent behind it is how we integrate those services. So be that in the acute hospital, be that in the community services, be it voluntary community sector or care homes, actually how we work in a more cohesive way to come around individuals. I think that's part of the benefit as well of routing it through the local care partnership arrangement. So some of those priorities and programmes of work that we've identified, it can act as a bit of an enabler around that. And we do have services that deliver, for example, we've got a hospital to home service that's delivered by UHP, so Derriford Hospital outreach and support people alongside the independence at home service within the council. And that's one of the things we're keen to look at, is actually how can we bring some of the coordination and understanding around that to make sure that we're making the best use of the resource that we've got, and also don't have any handoffs in terms of as people are moving between services.
Thank you. Just a quick one from me. I'm quite intrigued to know what you mean by affordable admissions, because as far as I was aware, well, I might be wrong, but you want to get admitted to hospital anyway if it is essential. So I'm kind of like stumped in what that actually means.
Thank you. No, that's a very good point, Chair. So nobody wants to go into hospital, do they? But there is something around individuals who, if we've got the right support offer for them in place, so for example, it could be a night sit for a period of time if somebody's had a fall, or a crisis response offer in terms of the therapy team, that means rather than necessarily somebody going to the emergency department potentially being admitted, if we can wrap around them, that helps us avoid that admission in the first place. So keeping people, turning people away from the door and wrapping around and supporting them in order to keep them safe at home. We're also doing quite a bit of work at the moment as well around individuals who are frequent attenders of the emergency department, and might be a number of complex reasons behind that, but actually using some of the data that we've got to identify people and wrap around them, using a team within LiveWell to actually identify what's the other support offers that we could put in place that help some of those people where they've got trigger points that might mean, or an escalation in their need, to help them stay at home rather than coming into hospital in the first place. We know for some people, an admission to hospital is absolutely appropriate, but it's about how we can support as many people as possible to keep them at home in their own bed for as long as possible.
Okay, thank you. Anybody got any questions? No. Thank you, Chris. Thank you. Thank you, Darren. So now we're going to go on to Future Hospitals Derford Urgent and Emergency Centre. That's Stuart Windsor and Amanda Nash.
Okay, we'll just let Amanda get set up in terms of the presentation.
Chair, would you like the team to introduce themselves to you? Because there'll be some of the members here that haven't met these fine people before.
So,
yes, please.
So my name's Stuart Windsor. I'm the Future Hospitals Director for University Hospitals Plymouth NHS Trust. So I'm the Senior Responsible Officer for the Future Hospitals Programme.
I'm Nikki Collars. I'm the Future Hospital Programme Manager for the Trust, delivering the new Urgent and Emergency Care Centre.
Hello, I'm Amanda Nash. I'm Head of Communications at University Hospitals Plymouth.
Thank you. So what we wanted to do today was give you a bit of an update in terms of our broader Future Hospitals programme, and particularly focus on the Phase 1 development. If you go to the next slide. We're really at a critical moment now in terms of the overall programme. Back at Christmas, we had the pleasure of presenting the business case for Phase 1 to the Joint Investment Committee, and that went through approval, and we've now had Secretary of State approval to proceed. So we're currently working through the full business case with a view that that will be submitted over the next few months, and that really is a huge opportunity in terms of making a step change in terms of the front door to Derriford. But I wanted to just set the scene first of all in terms of the sort of broader programme. So next slide. When the new hospitals programme funding was announced, and there's a bit of a time lag on the slides, we took the decision that we wanted to take a programmatic approach to development. Derriford is a complex estate sat in a complex system, and we wanted to make sure that we really understood what all of the opportunities were, and took a sort of incremental approach to development that wasn't just about a single hospital building over the next 10 years, but actually was a 5, 10, 20-year plan for how we needed the estate to evolve. At the heart of that was the Phase 1 development, which is sorting out the front door, the urgent and emergency care building, and that's the critical development. That's the piece where we've got funding from the new hospitals programme, and that funding is secure. In terms of other phases, we need to rationalise and ensure that we've got the right capacity for planned care, and as part of our wider site development plan, The second phase of development was about making sure that we had the right capacity for work that needed to be done in the hospital environment, but also take the opportunity to take services out of the hospital into the community where that was appropriate. The third phase was very much around our role as a specialist service provider across the peninsula and making sure that we had the right capacity to not only deliver the services that we need today, but cope with the demand change over future years. The fourth phase was then about women's and maternity services and making sure that we reconfigured that part of the site to again have the right services in the right place with the right level of capacity. The fifth phase was then around children's services, and that links very closely into the first phase, where we've taken the opportunity to think well ahead in terms of how you might create an integrated children's hospital that allows the flow from our emergency department front door in terms of paediatric services to flow naturally into children's assessment and other children's services. So that's part of the overall master plan. The last phase then is around sorting out the backlog maintenance in the hospital and ensuring that we've got the right bed capacity. So whilst there are different phases, those phases can happen concurrently, and actually they're broken down into smaller sub-phases. So that allows us to seize every opportunity in terms of funding to progress elements of that strategy, but minded of a much broader and coherent master plan. Next slide. I think that the case for change for the emergency department is summarised in the slide that will appear in a moment. When you look at the data, what we're starting to see is an increase in terms of both the average time where our majors department is crowded, and when you start to analyse that, we've gone from crowding for next to none of the time to crowding probably 23 hours a day now. And crowding, it's a complex position in terms of flow into the emergency department and flow out. What we are seeing, as you heard earlier, was no significant increase in terms of overall demand, but we are seeing a change in terms of acuity. So that's changing the nature of the patients that we're seeing and the treatments that we have to put in place at the front door. But crowding has an impact in terms of then the decision making we have at the front door, and obviously has a massive impact in terms of patient experience. So really the case for change for much of phase one is around making sure that we've got the right capacity at the front door to configure the services in the right way to provide services that are essentially front loaded and allow the best choice in terms of whether to escalate treatment and bring patients in or wrap around services at the front door and get patients back out into the community. So next slide. So phase one is part of the New Hospitals programme and is part of the comprehensive spending review settlement for this period, and therefore the funding is secure. We have taken the opportunity in terms of phase one to not just focus on core urgent and emergency care, so our emergency department and the same day emergency care services, but also some of the services we need to wrap around as part of our role as a tertiary service provider. So within the scheme, we've also taken the opportunity to remove one of the higher clinical risks that we're carrying at the moment, which is around our interventional theatre capacity, which we use for neurosurgery and we use for stroke services and others. We've also taken the opportunity to build additional conventional theatre capacity in that can be used both for emergency cases but also for planned activity. So it's an integrated building that focuses very much around urgent and emergency care but has some of the wraparound services as well. I'll pass on to Nikki in a moment to talk through each of the stages. Next slide. But we are at the point now where we've appointed a developer, Mason Wilmot Dixon, and we are working with them to finalise the designs with a view that we finalise the full business case and take that through approval. Nikki.
So the building itself is around 17,000 square metres in size, over 4 storeys. And we're at the stage now where we've started enabling works. We've secured around £15 million worth of funding from the New Hospital programme to start those enabling works, and that includes the rerouting of underground services, and we're hoping to start the build of a fracture clinic shortly on the piece of land we've purchased adjacent to the hospital, known as the North West Quadrant. We'll then start our main contract works early next year, and the build is going to take between 2.5 and 3 years to complete. But I just wanted to run through some of the levels now. So in terms of level 6, this is the same level as the main hospital entrance. It's effectively the ground floor of the new building, understanding the geography, the topography of the site. And that will be the main emergency department floor for adults and children, and it will also incorporate imaging facilities. There's then a new walk-in entrance and a separate ambulance entrance at this level. If we go to the next slide, level 7, this is largely designed around same-day emergency care, and that's the idea of being able to see patients, diagnose them, treat them, and allow them to return home within a 24-hour period. And this facility has also been designed alongside a short stay ward, further imaging facilities, and smaller emergency department rooms, so for examination and consultation purposes. On the next slide, level 8, this provides what Stuart was talking about, the 4 new interventional radiology suites, as well as adjacent patient recovery facilities. And what's really important is that this new building is linked to the existing hospital, which will make things easier for staff, but also for patient safety as well. So there's a clear link back into the existing hospital. And then just moving on to the next slide, level 9, this primary use of level 9 is for emergency surgery facilities, with 5 new operating theatres being provided. But this floor also provides administrative offices, welfare facilities for staff, and there's a real focus as well on how we can make these facilities as good as they can be to support staff well-being as well. Next slide, please. So this last slide is quite a complicated slide, but it's just really to give you an example of how we're phasing the enabling works. So we're very aware of how disruptive a scheme like this can be to patients visiting the site and obviously staff working there as well. And we're very conscious of the need to communicate well with all our stakeholders, both in and outside of the hospital. So we recognise, as Stuart said earlier, it's a constrained site. There are other building works also going on at Derriford. We've got to be very mindful of that, and access to areas can obviously be limited by clinical activity. So we're working with our contractor to look at out of hours working, weekend working at times when the hospital is less busy. And also we're conscious that we are going to be demolishing some of our existing stock. So the Plymouth Theatres building will come down. We'll talk about that in a moment. That will be particularly difficult, but as part of that process, we'll have traffic management plans in place and, again, clear communication on when things are happening and for how long. I'll just pass back to Stuart in terms of mitigations.
Okay, so clearly this is going to be a fairly significant building project in probably the most busy part of the site. So it's a complicated site. The construction methodology we've adopted for this is around off-site construction, so we're minimising the construction that needs to take place on site. But clearly there has to be a number of mitigations in terms of moving services around so that we are in a position to complete the building. And as Nikki said, the first stage is around demolishing what was the Children's Theatre block at Plym, which is the single-storey extension at the front of the hospital. Children's Services have already moved out of that building, and we're using those theatres at the moment as part of our elective recovery plans and to provide a frailty unit. The first big stage in terms of the enabling works is to create a new fracture clinic, and that's part of a building that's shown on the slide. The fracture clinic is currently located very close to the emergency department, and it occupies really the only space that we have where we can relocate children's services, paediatric ED, for the duration of the build. So the aim is that we move fracture clinic out towards the end of this year. We move paediatric services into that area, and that's where they will stay throughout the construction period. Once the new building is built, then the old emergency department will be converted into a dedicated and much bigger paediatric emergency department. And then at that stage, the team will move in. In terms of coping during construction, in terms of the disruption that will be caused, clearly there's a huge amount of effort at the moment in terms of managing our front door demand and managing flow. We still remain a really challenged organisation in terms of ambulance handover delays, although the delays are coming down month on month. We are making now good progress. So in terms of things that we will be doing, we are strengthening the capacity in terms of the urgent treatment centre in town. We've got a bid in for a further urgent treatment centre, which we are hoping will be determined shortly. As a precursor to that, we've set up primary care streaming at the front door, so patients that really need primary care intervention, we're pulling out from waiting for several hours in the emergency department to be seen by a primary care practitioner at the front door, and that model we're building and growing. Recently, we've added 40 new beds into the system through the discharge assessment unit, so thinking about the capacity we have in the hospital and patients that don't need to be sat in a hospital environment. That's a really good environment in which now to provide essentially some step-down care as we get patients back out and settled in the community. As part of the broader plans that Nikki mentioned, we have a number of schemes that are underway that are around increasing our bed capacity, and those schemes have been developed over the last couple of years, and we're starting to see the first stages of those open this year, and that again will help in terms of managing flow from the emergency department. So I think we are well set up in terms of what we need to do. I'll pass to Amanda to talk about stakeholder engagement.
Stuart. So obviously, as Nikki and Stuart have outlined, this is a massive project, and even to get it off the ground, we had to engage in really early stakeholder engagement with NHS England, with our local MPs, etc. And to stand an optimal chance of having success, it's really important that we engage with our staff, with our patients, with groups, everybody from Citizens Advice to the local Padan group. So we've began engaging really in 2018, and for those members who have been here for a longer period of time, you will remember us coming before committee with this plan before, back in 2021-22. So it's been a long period of engagement, and that's really continuing right to this day. Recently we've had a range of activities which some of you may have been involved in. We have been identified as best practice in the National New Hospitals Programme because some of the work that we've done to engage people, so we had a virtual reality dome that we invited people to come and step into or wheel into if you had a wheelchair, and you could experience what it would be like in the new urgent and emergency care centre, and that went really well with our staff. They particularly liked that. It's really important for them to be able to see it and feel it as it will be. We've held, in the last 2 years alone, we've held 100+ meetings, including many staff briefings. We've had our virtual reality dome. We've done lots of filming, and we've worked with our architects to come up with fly-throughs to show you what it will look like, and I can share those with you if you like. And there's our virtual reality dome, which will appear in a second, and it'll show you how you could step into that, and then you could experience what it might feel like in a much more modern UEC than our current emergency department. In summary, we have lots of activity going on to engage with a wide range of stakeholders, and that doesn't just include Plymouth, it also includes our residents in Cornwall who use our urgent emergency care services. So we recently attended the Royal Cornwall Show to engage with them. And in broad terms, we have really good support for this scheme. I think local residents and our patient population understand the real need for this. They understand what it feels like to be cared for in a really crowded department, and they are really supportive of this. Some of the themes that have come back from engagement include the importance of provision for mental health care and those patients in distress in terms of mental health. Staffing always comes up. It's great building this. Have you got the staff for it? And this, of course, is all fed back into our plan. So this is a virtuous circle of engagement feeding back into our plan. Further expansion in terms of beds, which Stuart has already talked about. Environmental concerns, we get asked lots and lots of questions, don't we, about how are we building these buildings in a sustainable way, and I think that's been one of our most popular themes in terms of feedback that we've heard, which is really lovely actually. Community care, how can you make sure that you treat as many patients and care for them, which you've heard about a lot from Chris today, at home. Access and car parking, and we continue to work with Padan around that. We know we're a really constrained site, and we are a bit like a building site at the moment with all the work that Stuart's doing. So that is a real concern for people, because we don't want our patients arriving into clinics in a stressed, in a stressed state. So that's really a concern for us. And Nikki's already spoken about staff rest areas. I think the well-being of our staff has, pre and especially since COVID, really moved up the agenda, and we're creating lots of well-being rooms. Stuart's team have created lots of themed well-being rooms in our hospital and our sites for staff, and that's part of our plan for our new urgent emergency care centre. That's just a little bit about what we've done recently. We've held lots of events with our VCSE sector to keep them appraised of what's happening and what we're doing. But in short, there's really good support for the plan, and we have a plan for ongoing engagement.
Okay, so we last came to committee in October 2022 when we sought your support for the outline business case ahead of submission and approval in December, and that support was really welcomed and formed an integral part of actually what we were taking to the Joint Investment Committee. Just next slide. In terms of the plan from here on in, we are currently working on the full business case. Enabling works have already started on the site, so if you visit the hospital, then you'll see there are some works taking place adjacent to the emergency department to divert some of our services away from what will become the building site. We are intending to submit the the full business case in October this year, September, October this year. That will go through an approvals process, and we're looking at approval by March next year, when the full works will start. But ahead of that, there's quite an extensive amount of works taking place, including the demolition of Plymouth, which we're hoping to achieve in the autumn of this year, and that will be the sort of a fairly significant milestone in terms of seeing the hospital change. Once we get into construction, we're looking at an opening date of December 2026 for final completion, but we'll be opening in a couple of stages so that we can open the new emergency department more quickly and then start work on the paediatric emergency department while we're completing the work on the theatres. So that's the programme from here. Last slide. So in terms of our ask today, as we work forward now to submitting the full business case, we're asking again for your support for the scheme, your ongoing support for the scheme. We also need to confirm that the scheme does not require public consultation as part of any letter of support. That's really important in terms of thinking about this scheme in particular, where essentially we're not changing the location or nature of the services that we're providing. So hopefully you'll be able to confirm that we won't have a requirement for public consultation preceding the submission of the full business case. So that's it in terms of our update, but really happy for questions on any of this.
Okay, thank you very much. I have got two councillors that would like to ask questions, but I understand that you've gone it for consultation, and you've done quite a lot of consultation. On the if you don't go to consultation again, is there anything that would be missed, and what would be the benefit for not going out to consultation, any more consultation?
Yeah, so I guess we've done a lot of stakeholder engagement that's helped shape the building and the services that we're going to deliver. There is a step around formal consultation, if it's required, where there is significant service change, and that would be a prolonged process that would need to consider what the options were for potentially delivering services in different locations across the city. So we believe, based on the work we've done so far, and you gave your support last time to the fact that we don't need to go to formal consultation, but in lieu of that, we've done a huge amount of stakeholder engagement that's helped to shape. I don't know whether, Mandy, you want to add anything to that?
No, that's absolutely it. There's a big difference between engagement and consultation. Consultation is a legal requirement if it's about considerable service change, particularly that comes into play where there's perceived to be any loss, etc. And that's certainly not the case. This is about improving the services that we have, and I think that's why we've got such full support for it in the engagement work that we've done.
Okay, thank you. And just one more thing from me. When this work is going on, up at the hospital. Um, I'm quite interested in the construction hours from when you start work and when you finish. And the reason why I'm asking that is because I was in a ward when there was a patient on end of life, and work started at 7:30 in the morning and went on until at least 8 o'clock at night, which wasn't very, what can I say, very nice for the family that were actually in that room, and that's all they had all day. So I just kind of like would like to know what kind of hours that would go on for.
So we are bound by the planning consent restrictions in terms of hours, but what we try to do is to work around activity in the hospital. So through our network of clinical leads that we've appointed to support us in the project, we do regular engagement to understand what activity is going on in the hospital and whether it's appropriate to be working in certain areas. And if it isn't, then we stop work. So we've been very clear with our contractors that for this building in particular, that approach needs to be taken as well. And that's why we'd be looking at doing some weekend working, some out of hours working where we can, but to try to mitigate the impact in terms of noise disruption throughout the hospital.
So the first stages of development will probably be the noisiest, where we essentially demolish Plym and we get the foundations ready. The rest of the construction, so all of the concrete frame will be constructed off-site and then brought to site and essentially craned into place. So we're expecting that to be less noisy. We have done a review in terms of the services that are located closest to the emergency department. Clearly there will be some disruption to the emergency department, and it's important that we try and get patients in as quickly as we can from ED. We are taking the decision to move some of the services that are closest to the building site. So neurophysiology is one service that is just on the cusp of potentially being affected. But given the nature of the services that they deliver, I think it's appropriate to move them away from the construction zone. But then we'll manage the impact in terms of the rest of the building, as Nikki said. The wards are a fair distance away from the building site, but clearly sound does travel.
I'll probably agree to disagree with you on that one because I know.
Yeah.
Councillor Salmon.
Thank you, Chair. Start off by saying no doubt this is going to be an absolute boon to the city. But you mentioned just now about you don't want people arriving in a distressed state. I always arrive in a distressed state. A couple of weeks ago, I had to go for a CAT scan. It took me 40 minutes to find somewhere to park. Everywhere was full. You put the helipad in, which obviously cuts some out, but it's very necessary. Just looking at your site development strategy slide there, phase 2, new build plan care centre, appears to have taken out the disabled car park because it's right next to opposite on the car parking thing. So, the car, you mentioned the car parks you're looking at. Everything else has been basically sorted. You've got your building structures, you've got your underground stuff, and you're just talking about car parks. It's been like this for years now, and with the additional numbers coming in, that can only get worse. So what actually are you going to do about improving the car parking facilities, please?
Okay, so there's a number of things that are currently happening. So we're currently out to consultation with staff around our updated sustainable transport plan. So we'll be publishing a new plan towards the end of the year. And part of that is making sure that we get the right balance between staff parking and public parking on the site, because I'm acutely aware that we haven't got that balance right in terms of patient access. In terms of development, there is a lot that has been happening on the site that has taken car parking capacity. Clearly, we've lost the car park around the helipad. We've lost the maternity car park, so there is a reduction in spaces. So we're currently working with partners to identify additional off-site parking to support our staff car parking needs. So again, that's part of the overall jigsaw. In terms of the planned care centre, we have mapped out two options, and we're not yet sure the extent to which we need to expand the building versus build a separate building for planned care. What we would like to do very much is move as much care out into either the community or into a separate building on the site as we can, and then make sure that we use the building for the services that absolutely need to be delivered in a acute hospital environment. And that may mean we don't need to expand the building. Our preferred site for a planned care centre as part of our sort of overall master plan is on the northwest quadrant. So it's the land that's up near Rowan House and next to the multi-storey car park. We've published a sort of placemaking vision for that site that includes how we will handle the car parking as a result of that construction, and that will be through a further multi-storey car park. So as part of sort of the next stage of very large scale development, we will be looking at an additional car park on the site to replace the capacity that's lost. But yeah, absolutely understand the position in terms of car parking on the site and access.
Thank you. Can I just ask then that you'll, obviously once this gets going in the various stages, you'll report back to the committee regarding the parking respective of each stage, because the car park you've just mentioned was also full, and it always is, as you know. Thank you.
Absolutely, we'll do that.
Councillor Nicholson.
Thank you very much indeed, Chair, and Stuart and colleagues, thank you very much indeed for being back before us today and giving us an update. You know, it ultimately will be a first-class scheme, so keep up the good work. Just in relation to the point that Chair, you raised about the sort of formal public consultation versus not having a formal public consultation, I think it would be useful for this committee and its work programme to have an update in due course in relation to the 6 phases of the scheme, in relation to what services are going to be moved out of Derriford into the local community, because Anne James did come before the committee quite some time ago, and there are activities at Derriford that shouldn't be based there, and obviously the intensity of services to be provided in the future requires certain services to be dislocated from Derriford and put back in the community. I think that's where formal consultation, you get that clarity of detail. So I think it's important that if we don't have a formal consultation, that you actually set out to councillors in the community what the plan is in terms of what's being taken out of Derriford and where it's going to be located in Plymouth or the wider hinterland. So that would be very useful. I apologise really to just emphasise the point that Councillor Salmon's made. Having recently taken a very frail and elderly relative to Derriford, it's not so much car parking, it's the ability to drop off. And the whole congestion that exists immediately outside the front entrance, where you've got Marks and Spencers and some limited car parking spaces. I'm not sure if they're designated as drop-off spaces, but generally people are parked in them rather than literally dropping off. And I think there's a piece here in terms of communication. It's only going to get more difficult. But I think that unless you're able to walk a distance, you really can only drop off at Derriford or use public transport. And we need to get a better, I would suggest, emphasise the methods of dropping off and picking up and the limited car parking. And the concern I've got is very elderly people can't walk very far. So you need to be able to drop off, you know, literally over a couple of minutes, and then whoever's driving, you know, disappears, and then the accompanying elderly person is then taken to the respective area of Derriford. That's becoming increasingly difficult, A, because you've taken away so many of the disabled parking spaces, and because the site is just so congested. So I don't know if you could take away trying to come up with a solution, just while I say, there's an awful lot of space where buses should occupy and where really the buses aren't permanently there. They're in and out, aren't they? Whether there could be a reconfiguration for sort of more temporary drop-off space where the buses might occupy, where it could be shared with the buses. Because ultimately even the taxis are competing with the citizen who turns up with their relative or their friend. And it's just, you know, it's not going to improve. And I think it's definitely something that needs to improve, because ultimately old people just won't be able to access the site because it's just so difficult, and it will have an impact on times, on appointment times. So, you know, I share the concern that Councillor Salmon's got, but I'm not sure parking it will improve for any foreseeable future. But we need to try and communicate and improve the drop-off mechanism. Just the flow there doesn't work. So, Chair, thank you very much indeed.
Yeah, so in terms of the visibility, in terms of consultation around the wider 6 phases, we are still at a very early stage in terms of working out what services might go where. but absolutely we will bring back and share those plans as they develop. We would expect the next phase very much to focus around planned care, because that's the sort of capacity gap that we have. And that will be a really good opportunity to think about actually what needs to be done in the hospital and what actually can be done in a lower acuity setting. In terms of drop-off and access and particularly the distances to get into the hospital from areas where you can drop off, we do have a shuttle bus that runs from the disabled car park. I think there is more that we need to do to promote and ensure that is running consistently, so that we've got a service that people know that they can rely on. So absolutely, we'll take that back. Thank you.
Councillor Watkin.
Thank you, Chair. I too think this is going to be an excellent scheme when it's finished, but what concerns me is that you've got a very tight time scale to get it done by 2026. And I'm not sure from what you're saying whether you've even got planning consent yet for the building. These things all take time, and it just concerns me that it's going to stretch from 2026 to sometime in the future. And there's going to be a whole mess up at Derriford in the meantime.
Yeah, so in terms of planning consent, we already have planning consent for the building. There are some changes that we need to make now that we've got the developer on board and we're just going through the planning process. We don't believe those will be material changes, so we're just working that through, but we do have full planning consent for the building. In terms of where we are within the National Hospital Programme, we are in what's called Cohort 2, and that's a series of smaller schemes which have been prioritised for delivery ahead of 2026. So we have funding security, and providing we can stick to programme in terms of getting through the approvals process, we will then move very rapidly into delivery. So the contractor's on board, ready to go, and clearly any delay that we have will mean ongoing costs as we've got the developer sort of sat waiting to build. So everybody is conscious of that, including the national team. So I think we've got the best shot at making this happen as quickly as we can.
Thank you.
Councillor Ricketts.
Thank you, Chair. Just for clarification, is this a new hospital or an improved hospital? And what's the total cost?
Go on.
This is phase one, a new urgent and emergency care centre, and it's phase one of our future hospital's ambition. And the total cost I'll hand to Stuart for.
Yeah, so the total cost is upwards of 150
Sorry,
million.
I didn't catch. Is this a new hospital or an improved hospital? Sorry, I keep hearing different things about this. Is it new or is it improved? It seems to be in the same place.
So we are part of the new hospital programme. This is phase one of our redevelopment programme. It is a new building that will be attached to the existing hospital building. But we are part of the government's new hospital programme.
Okay, what's the total cost?
So in terms of the
from
total
start to
cost, it's
finish?
upwards of £150 million.
And Chair, the only thing that confuses me is that that's obviously a massive amount of money. It's one of the biggest projects in the city. I've never seen something in front of me where you're asking for a letter formally expressing that this doesn't require public consultation. I've never voted for such a thing before. We always fight for public consultation. What's the rationale? I'm completely confused.
Yeah. So, do you want me to take? So, essentially, the public consultation process, as far as healthcare change is concerned, is a formal statutory process where you're intending to make significant change to either the nature of care that's provided or the location of that care. So if we were looking at taking the emergency department away from Derriford and building a new emergency department in Plymouth, then that would require public consultation. We've taken the view, and was supported in terms of your view back in October 22, that we didn't need public consultation because we weren't making a material change to the nature of the care that's provided. We are still providing urgent emergency care, and we're providing it from the same location. So it's a statutory process as part of the development of very large-scale capital programmes.
Okay, just on a personal note, with the sums of money we're talking about and the size of the scheme, I personally cannot support. I mean, the committee can vote on it accordingly, but I struggle to support, that kind of what you require there to have no public consultation. I think it's too important.
Councillor Ricketts, you have been given the reason why it's not going out to public consultation. It's not our scheme, it's their scheme.
Yeah, but they're requesting our approval of their view.
We're going to be given, well, the recommendation is that we give a letter of support to this scheme.
Yeah, confirming that the case does not require public consultation.
There has been consultation.
Yeah, but that's what they're asking for, and I'm saying
Councillor
I disagree.
Ricketts, there has been consultation. There was consultation started in 2020, as you've already been told. I am not going to get into this argument now. We will do I will ask for a recommendation for a letter of support from this committee. Whether you choose to support it or not, that's your choice.
Chair, I mean, I would be worried if we go to further consultation, there's going to be further delay, and certainly we need a new emergency department and all the associated operating theatres as quickly as possible. So I don't really quite see what a public consultation would yield anyway, so I think we should support it. That's my view.
I've got one more question from Councillor Noble, and then that's it. We're going to go to, no, that's the last question. Then we're going to go to a vote to see whether we send support a letter of recommendation.
So just two parts of the question. One, is this scheme funded? Is it guaranteed, the funding for the extension to ED? And in terms of like a future hospital, I mean, Derriford Hospital didn't exist 50 years ago, and it was somebody's vision to bring things from umpteen places into one hospital building. And obviously, you know, as things have moved on, starting to do other things. And obviously throughout the site, you've got the, when we refer back to the other part of the report, the planned care 104-week wait, the commentary refers to orthopaedics and urology, so the maternity car park extension there, I understand that's an orthopaedic ward. Level 2, where site services used to live, is going to be theatres. Oncology's had an extension or having work done now, isn't it? There's the bit in the car park, the gravel pit car park, there's a bit of ruins. It's like a road, you're adding another layer to a Rubik's cube and then moving it round and then taking, you know, so there's that type of but how these things are, some of the facilities that we're putting in, or that's growing in the hospital's growing, if you like, and to meet sort of current needs. We've had lots about the ED, you know, the needing to be and a new hospital with a new extension with these facilities will obviously help that. So I suppose my question is, you know, what about the longer term need? Because what's going on at the moment seems to be responding to what we currently need, what the current sort of shorter to medium term needs are.
It's a really good point, actually. So in terms of the money, it is funded. So there is, we are part of the new hospital programme business case nationally, and there is an allocation for Plymouth. So providing we get through full business case and we end up with getting through that gateway, then we'll move into construction, and that budget exists as part of the spending review settlement in this parliamentary term. So we've got the best opportunity really in terms of drawing down that funding. In terms of the wider programme, you're absolutely right. There's a lot going on across the Derriford estate, and it is very much around trying to plug some of the capacity gaps that we've had up until this point. So what we've tried to do is take a bit of a step back in terms of creating our site master plan, to think about this in the context of where do we need each of the services to be, and thinking about the scale of those services and whether they'll fit in that part of the site. So we've got a broad master plan that says we're going to bring certain services together, and there's an opportunity to take some services off the site to create the breathing space. What we've tried to do is build it in that way so that we can seize opportunities for smaller amounts of funding to take us a step further towards. So the orthopaedic theatres, for example, was as a result of a national call around capacity for elective recovery. And so building the capacity actually solves one of our real challenges around our 104-week wait position, and we've taken that approach throughout. In terms of the work that's underway at the moment to think about the longer term, we are in the process of updating and refreshing our clinical strategy. And the approach we've taken is service line by service line. We're working through what the current needs are in terms of the population, what we've got in terms of capacity, what's the nature of the service, and thinking about the service changes that will be needed on a 1, 3, 5 and 10-year horizon. And that includes services where we may end up taking things to a lower acuity setting. So urology is a really good example of that. We're now doing a lot of work in the urology unit that historically would have been done in the theatre. And if we can pull that activity into that lower acuity setting, then we end up with the capacity released in the theatres to do other work. So we're working through that picture across all of our service lines. And then what we're doing is we're testing that against the site master plan to make sure we can physically accommodate everything we need. And that's what will lead us then to what are the bits where we do need to pull services out to create the additional capacity, and when do we need to make that happen. So it is a big jigsaw. We're trying to do it almost in Lego blocks so that we understand the component pieces. When you look back at what you've created, actually it makes some sense as a whole. That's what we're trying to achieve.
Thank you. I think what we'll do now is we're making a recommendation. So the recommendation is that this committee supports, sends a supporting letter for this project. Those in favour, please put their hands up.
Through you, Chair. Sorry, before you vote, I think it's important that your recommendation does include that you specifically excluding consultation. It's part of the remit of this panel, and therefore you should have a positive vote if that's what you wish to do.
Chair, can I suggest a slight amendment to the words which might help the situation? So we've got the health community saying they don't need, for the purposes of health legislation, to go through a consultation, but saying there's no consultation is not actually accurate. So why not say, basically the committee confirms the case does not require public consultation insofar as health legislation is required, but full consultation regarding future planning applications will still go ahead. That sends a message to the public that the public will be consulted on the development, but not in terms of the patterns of healthcare required through health legislation.
Yeah. So with the amendment of those.
Stuart, want to come in?
So I think we just, in terms of the letter that comes back, I don't want to get caught in a position where somebody is misreading the language that's used. So I would feel happier if we majored in terms of the stakeholder engagement as opposed to using the term consultation. As consultation in a health perspective does have a particular connotation in terms of the processes that we need to go through.
I think the letter would be down to the council to craft. The recommendation before us today is that effectively you're asking us not to require health service changes consultation, which I'm happy to support. But I think the message to the public is there will still be public consultation in terms of the built environment at Derriford through the planning process. So they're not excluded from all public consultation.
Through you, Chair, we can craft a letter in that respect. Clearly, Councillor Nicholson is referring to the statutory planning consultation requirements that we would require for all applications. So this isn't the panel, this committee doing anything out of the ordinary. It's just being very clear what we would expect going forward. So we could craft that letter without any problems. It certainly would do us well to reflect on the ongoing engagement we've had since 2018, numerous member briefings, etc., and we can include all of that within the letter.
Okay, so those in favour?
Apologies, Chair, I'll need to be at a Plymouth meeting, sorry.
Thank you for your support. Yeah, okay. So what we wanted to do is just give you an update in terms of the Community Diagnostics Centre. So if you want to the next slide. This has, again, reasonably long heritage. So back in 2020, there was a report by Sir Mike Richards that looked at diagnostic capacity across the country and proposed the introduction of a series of diagnostics centres to act as essentially the sort of front-loaded diagnostics that the country needs. At the moment, a lot of the diagnostics is centred in our acute hospitals, and actually that's not necessarily the right setting. The government launched a programme around implementing a number of the recommendations out of the Sir Mike Richards report, and that led to plans for a number of very standardised diagnostic centres to be built across the country, with the intent that there was a hub in the majority of systems that actually needed them. So we've been working on a business case in support of this for some considerable time now. There is a hub already in place in Devon at the Nightingale Hospital, and our original intent was to be a spoke of that hub. As time has moved on, we've developed the case for a hub in our own right because of some of the particular challenges around the Plymouth system and access to diagnostics. So we are currently in a position where we submitted a bid, and that bid has been approved, and we've been notified of that approval, and £25 million has been earmarked to create a community diagnostics centre, which will be in the city centre. Next slide. So the next slide is very much around the overall CDC programme aims, and it is very much around early diagnostics capacity. So having something located in the city centre serves two purposes. It provides capacity that's easily accessed, but it's also capacity that is very close to some of our most deprived areas, and we know that early access to diagnostics is critically important. It fits in terms of the overall work we've been doing as a Plymouth health and social care system around where we need capacity across the Plymouth system. It's part of our overall blueprint. Very much primary care facing, and this is new capacity. This is not about taking existing capacity out of Derriford and putting it into a new building in the hospital. This is about absolutely new and funded additional capacity. I'm going to pass on to Nikki, who'll talk about the standard approach that the country is adopting to CDCs and what we're planning for Plymouth.
So because of the value of the project at £25 million, as Stuart said, we fall into the design criteria of a standard CDC build. And really this is about delivering a variety of diagnostic tests, including those tests that are deemed to be a priority locally, and that's the key point. It will also include some consultation rooms to increase efficiency, but essentially it's a very functional building, and we're working in partnership with the council to develop that design. Next slide, please, Amanda. So our CDC will be built on the Colin Campbell Court site in the city centre, and a condition of our approval is actually the delivery of some temporary diagnostic capacity by the end of September this year in a mobile unit, and then we're working on the permanent build in parallel with that temporary capacity being delivered. So our temporary capacity will be effectively a CT scanning unit, including welfare provision for patients. And we're just working to determine exactly where on Colin Campbell Court that will be located. Next slide, please. The benefit of the Colin Campbell Court site is that it's largely cleared, apart from some crushed material, which the council will reuse elsewhere. And we're working very much around transferring the freehold interest of part of that site to our ownership in order to build the permanent facility, and also to arrange a licence for that site of the temporary activity adjacent to it. So we're working with the Strategic Development and Urban Design team so that it can complement any future development around it. But what's great about the Colin Campbell Court site is it affords excellent access to public transport. It also supports the Trust's aims to achieve net zero carbon emissions. And this means, crucially, that patient access to diagnostic services is not limited by car ownership, for example. Just go to the next slide, thank you. So what's inside the CDC? Well, the proposed services that our bid is predicated on include 2 CT scanners, 2 MRI scanners, either 1 or 2 X-ray rooms. We're just determining exactly what we need in terms of X-ray. And it also includes 4 ultrasound rooms. There'll be point of care testing and an audiology suite. Part of the new requirements, because of the standard CDC building, will include echocardiography, blood pressure monitoring, and some spirometry and pacemaker checks. So it's going to, by the end of 25-26, we'll be providing additional capacity, for example, 34,000 further CT scans than we do currently, 9,000 further MRI scans, 39,000 further ultrasound tests, 9,000 more X-rays, etc., etc., 2,000 audiology assessments. So it's a great boost to the city. Next slide, please. So I mentioned before about this 2-phase approach, the idea of delivering some temporary capacity by the end of September, and then the main build being built in parallel with that, and opening on the 1st of April 2025. And so what we've done is, since getting the approval, we've remobilised our design team. We've started weekly working group meetings. We've got a project board established with the council to make sure that we're working in partnership on the design of the building, and also in line with the council's master planning. And the intention is to do engagement with patients and members of the public as we work out that design. And the overall building size is around 3,500 square metres, so quite a significant build on that footprint. That's our last slide, so we'll just pause for any questions. Thank you.
Any questions? Just
to say, Chair, that this is actually coming under Councillor Lowry's portfolio, but obviously him and I have conversations about this. But you know, it's a brilliant opportunity, shall we say, for these services, and it won't just be restricted for patients down or people living in this bottom end of the city. It will help completely with Derriford, but down. You know, if we think about St Peter's and the areas there, it will save them getting buses up to Derriford and all of that. So, you know, it's a good opportunity, but it's one that we need to make sure that it's, you know, we make sure that we maximise the use of it, definitely.
thank you, Councillor Aspinall. Councillor McManara.
Thank you, Chair. It's a fantastic thing, all in favour of it. I just wondered, why are you going to have the temporary thing on the building site? Couldn't you have it somewhere else in the city centre for easier access, because you're going to have disabled elderly people in the area? Thank you, Chair.
It is actually a condition of our bid to have it in very close proximity so that we can start to advertise, I suppose, the service that will be there in the future. What we're working with the council on is the exact location being potentially the other side of Colin Campbell House. So there'll be a sort of clear break between the 2 sites so that it shouldn't be interrupted by the building work, the construction work itself. And that's the intention. But we don't have an exact site location yet. But yes, you're right, very conscious that we don't want to interrupt the main build process or cause any difficulty with access.
Okay. Angela.
Thank you, Chair. Could you just fill us in on the funding situation? I'm sorry, I may not be up to date.
Yeah, so again, there's a national programme that is in response to the Sir Mike Richards review. That programme is around creating the standardised community diagnostic centre. We submitted a bid, that bid has been approved, and we've been awarded £25 million. So again, we're part of an agreed national programme. It does come with a considerable number of things that we need to do, and as Nikki alluded to, one of those was getting activity on the site early, and we're just at the process now of working through all of the conditions that are on this with our Plymouth City Council partners to just make sure that we can put everything on. The allocation has been granted and we've been notified. And I think there was a national announcement to that effect.
Thank you. Any more questions? We'll take this one and then that's the last one. Councillor Noble.
this is we heard about the health hub that was happening, and that was taken off the table. And is this instead? Is this a similar project instead of, or is I don't know whether Mary or
Just to say, it's a different project, but it's utilising the Colin Campbell car park as the start. And if you think about what our ambitions are for that area, it's that start to that. Now, whether you want to call that a health village or whatever you want to call it, you know, certainly to Councillor Lowry and myself, it seems a darn good opportunity, shall we say, to make sure that we're making that start, but also it's utilising the money that the hospital has been able to, Stuart and the team have been able to get. And since the Cavell Centres didn't succeed nationally, I'm not saying it's a poor choice for sort of, but it's really brilliant that we've got this the diagnostic centre, and we've got the site available for the hospital to be able to use it.
Thank you. Can I thank all three of you for coming along today and giving us an update? Thank you.
Thank you very much, and thank you for your ongoing support.
We're going to move on now to motion of notice defibrillators. I'd like to welcome Councillor Terry Beer, who actually brought this motion to full council, and we're going to have Ruth Horrell to give us an update.
Thank you very much, Chair. So there's a paper in your pack, and as you say, this was triggered by the motion on notice that was raised at the council meeting at the end of January. So the issue of defibrillators is one which is not, you could say it's not one person's responsibility or one organisational responsibility to deliver and to make sure that there's a provision of defibrillators across the city. So you could argue it's all of our responsibility. And so rather than just look at council buildings, I felt it might be appropriate to widen that. And in this paper, I've tried to give a bit of a summary of how we could look at defibrillators across the city and understand a little bit more about where they are, how we should be using them, and also the other things, the other skills that would be beneficial to promote around that. So as a very brief introduction, I'm sure you're aware, defibrillator gives a jolt of energy to the heart, which can help to restore the heart's rhythm to get it beating normally again. And this has to happen quickly in order to increase the chance of survival in those people who have suffered this incident. And it also needs to be delivered with CPR, cardiopulmonary resuscitation. So there's that sort of package is absolutely essential. It's a really simple piece of equipment to use. It's been made very simple to use, and it doesn't require training to actually use the equipment. And it's important to be able to find and use a defibrillator. I'm going to call it a defib, otherwise I shall keep stumbling over the word. It's important that people are able to find one in an emergency. So the use of defibs is relatively small. So taking some very approximate statistics, it might only be about 30 cardiac arrests a year in the population of Plymouth in public spaces. And so it's really, really difficult to predict where might you need one, and therefore to plan where should you have a defibrillator. So it is quite difficult to do that. So the British Heart Foundation and various other people recommend that we consider how many people might be in particular areas, and also that the age, the demographics of those people, because as you age, the risk gets higher that you may have heart disease that might lead to this incident, and also the type of location as well. And it is important that we note it's a relatively low cost device and it could save a life, so it is important. And as you can see in the paper, the cost is something around £2,000 or so for a defibrillator. And obviously you'd want an external cabinet if you want to make it available to people in an easy way 24/7. There's a few commitments and ongoing costs, but they're relatively low. So one is a commitment to check that the defib is still there, is intact. And another is to replace the batteries and pads. That's relatively low cost and relatively infrequent, as you can see in the paper. So First of all, there's a question about where they're sited, and actually I wanted to flag something called the circuit. So this is what the ambulance trusts across the country are really trying to promote, is a national central database so that they have access to where defibrillators are. So the idea of the way it should happen is that if there was an incident where you thought you may need to use a defibrillator, you'd phone 999, you would get talked through what to do, how to do it, and where your nearest defibrillator is. So it's really important that our ambulance trusts across the country know exactly where these defibs are. And so one of our first actions might be to make sure that all of the defibs across the city that we know of already are registered on the circuit. So one of my recommendations is around promoting that, so that the ambulance just are able to signpost to the nearest one if that should be necessary. Then the question of, do we need more? Well, there's no standardised measures, there's no simple way of saying how many we might need. So initially, we've taken Plymouth City Council and our own council buildings, we've looked at the proximity of defibs and the British Heart Foundation guidance and come to the following conclusions, which is that the vast majority of our sites do already have a defib, which is in close proximity, or indeed one within the building, and therefore could be used. But there were 6 areas that were identified where we do think we should take action to increase defibs. And I beg your pardon, that should say 5, I think. Small error in the paper there. And so we've made a series of recommendations which the team are already enacting, and that includes a defib in the area of the Guildhall and the Council House. And for reasons to do with the installation, I am told that the Guildhall is the preferred location for that. So that is going to be put in place. Considering the city as a whole, it's not possible to say how many are needed. And so I'm making the recommendation that what we should do is, as well as promoting the use of the circuit, so all defibs are registered on that, we also could be asking defib owners whether they would consider making access 24/7. There's a lot of defibs in the city that are there for businesses and for their workforce. They've been put in place to support their workforce. And so it may be that they, and currently they're available during working hours. And it may be that some businesses may be able to put a defib in a cabinet on the outside of their building to make it more widely available. And also, we know that occasionally there are schemes to access funding to support the purchase of defibs amongst communities. And so another thing that we'd like to do is promote any schemes that come to light. We will be looking at actively to find any funding support, and then promoting those to our community voluntary sector and across our city to widen the reach of those throughout the city. There's also a couple of elements around public awareness that I think it would be worthwhile us picking up that I've made recommendations around. And one of those is that on the 16th of October, there is a day, it's around that day each year. There's a day called Restart a Heart Day, and that promotes the use of defibs, but it also promotes CPR training. And that is actually available. It takes only about 15 minutes to do, and it's available online. So as well as other ways of accessing it, one of the other recommendations then is around promoting public awareness of what you would do if somebody was having a cardiac event, how to support them, what you need to do, and awareness of defibrillators, etc. So in summary then, on the back of the motion on notice, the specific answer to the question was that we have identified a number of sites, council buildings, where we do need defibs, and one of them is the Guildhall, so that it's very quickly accessible from the council house or the Guildhall. But we think there are wider things that we can do to promote and to support communities in making sure that there are widely accessible defibs across the city. Thank you.
Thank you, Ruth. Councillor Beard, do you want to respond to that at this present time?
Yes, please, Chair. And just to add that my motion on notice was brought in good faith. It went a bit awry in the council chamber because my concern was that this council house doesn't have a defibrillator. What I recognise also there are councillors in this building who have heart conditions, and I am one of them. So as you know, a heart attack can happen to anyone at any time. So I could be here now, gone the next minute. Where's the defibrillator? Well, the Guildhall is across the way, and with your trainers on, you could get across there fairly quickly and get back. But every minute is crucial without this piece of equipment. So my main theory of bringing it to the council was to get one for this building in particular, but also to look at the wider council estate and actually incorporate a defibrillator at all our buildings that are used by our staff and the public, and also have access, as Ruth has said, to have an outside defibrillator. So that was my intention. So I'm glad we're here talking about it, to be honest, because I think it's critically important. Now, just a little example I thought I would bring you today. A gentleman called Mr. Kelly, who was a former councillor, was at a public meeting and was feeling poorly right from the start and ended up having a massive heart attack. So for 40 minutes, he lay dead on the floor of the actual community centre. Fortunately, there was a couple of doctors there in the audience, which was helpful. There was a defibrillator not too far away, which was very helpful, and CPR had happened. As a consequence of that, Mr. Kelly has recovered from his heart attack to a degree, but there was some injury from the CPR. So, because it's a brutal act, that's pumping, that Nelly the elephant pumping. I am CPR trained myself, so if it did happen this afternoon, I would be jumping in there to help anyone in need. So that was my objective. I'm glad to hear your recommendations, Ruth. I think they're a step in the right direction. I still want one in this building. That is what I want. £2,000 is peanuts for a life saved. I'm sure people think, members of the public think, well, perhaps a councillor's life is not worth saving sometimes because of their political points of view. Any life, to me, is worth saving. And if it's £2,000, that is chicken feed to this council. So thank you, Ruth, for your recommendations. It's a start in the right direction, but I really do want one in this building. Thank you. Thank you, Chair.
Thank you, Councillor Beale. Councillor Aspinall.
Thank you, Chair, for that, and certainly, you know, I'm very content to have a look at that again and see what he said about that. Certainly, we would work very happily with our partners to promote a Restart a Day, a Heart Day in October. But there's a whole lot of those recommendations there that would be very good to take to the Health and Wellbeing Board, where more of our partners are around the table. So we have a Health and Wellbeing Board meeting on Thursday, so I'm very happy, Elliot, if we put those on that. But as for looking at another site on our council estate, I think Ruth and I will need to have a dialogue and to see where we go with that. But certainly we are saying that the Guildhall's a good site, and we will pursue. Presumably that will depend now on getting the Guildhall revamped and whatever. So I think we need a conversation about that, Ruth, as to when we're going to have to plan that. And we will certainly, I will listen very carefully to what you're saying there, Terry, and we will look and see what we can do about this building. Okay.
Thank you.
Thank you, Councillor Aspinall. Councillor Tippett.
Thank you very much, Chair. It's really good to have this in front of us today, not least because when this motion was brought to full council in January, I didn't think that 2 months later I'd be the person running to get a defibrillator out of the thing and taking it to save former Councillor Kelly's life, which is, you know, it really makes you realise just how important it is. After this, I did email Democratic Support about having CPR training to deliver to councillors, and I was wondering whether that could be expanded to make sure that all of this is included as an all-members briefing, and whether that could be added as a recommendation, because we are seen as leaders in our communities, and I think it's really, really important that we understand all of this and what we can do to make sure that our residents can access this as well. Thank you.
Thank you, Councillor Tippett. Councillor Riley.
So that's not my laptop because it's away. Hi, Rose. So I have actually spent most of today trying to sort out a defibrillator in Ernest that has been there for quite some time but has never been used. And there was an incident a month or so ago where a lady from the care home next to it, 999 was called for her. They couldn't access it. It wasn't on the system of 999, or it wasn't on the map. Turns out that it was bought by a fundraising. It was fundraised by a community group, who then failed to register it, and it hasn't been looked after since. So I was wondering if there is a recommendation somewhere maybe to have that kind of community focus. I know we did this community empowerment thing, but no one seemed to know, and it's taken me all day just to work out who I need to speak to, where it comes from, how we fix it. And they had no idea, so they bought it, they paid for it, and it couldn't be used at all.
Thank you, Councillor Riley. It is in one of the recommendations. Councillor Salmon.
Thank you, Chair. Just a question for Ruth, if I may. I want to put a bid in, please. You're putting these into the 5 defibrillators in the Guildhall, etc., and 2 others for the libraries. The Plymouth Library, I believe, has got about the highest footfall in the city. And the 2 wards, Radford and Dunstone, there's something like 65% of the population are elderly and therefore at high risk, but it's not on those library sites. Would it be possible to have a look and see if that's the criteria would be met, please? Thank you.
Yes, certainly. I mean, the 59 other council buildings have already been assessed as having a defib either on their premises or very close proximity. So that's the reason why they're not listed, is because it is already in one of those categories. But I can ask the team to look at the list so that I can tell you exactly where they are.
Thanks very much. Thank you, Chair.
Can I just remind all members that councillors can actually purchase a defibrillator from their community grant money. So within your own wards, you could actually fund one for yourselves if that's what you feel that you like to do. We've done one in Efford. Don't know where it is, but we have done one because obviously, like Councillor Riley has said, it's not been registered and it's just stuck in a cupboard somewhere. But I will be chasing that up. So, but yeah, there is no reason why councillors cannot fund any defibrillators through their community grant monies. Councillor Aspinall.
For instance, in Plymstock, you may well find there's one outside the fire station, for instance. So I think it's a case of now you know that they're around. I think all of us will suddenly start noticing the boxes outside of buildings that we hadn't twigged that were there before, or hadn't twigged what they were. So I think, Councillor Salmon, your homework is to play I Spy and see what you can find around Plymstock, and I'd be very interested to know what you find by just having a look around. I think saying that challenge to anybody. I mean, Ruth and the team have had a good look around to see where they are, and I think it's been that starter, and I think we're not going to be complacent, and I think that's why we need to take it to the Health and Wellbeing Board, because there's a lot of other organisations that work within the Health and Wellbeing Board that have far more tentacles than we do. So I think that'll be useful.
Homework accepted, Councillor.
Thank you, Ruth. So I'd like to put to the committee some recommendation. Sorry, Councillor Tui.
So I would just like to say that Ham, Tudor and I have put a defibrillator in the Morris Baptist Church, which was very welcome. And another comment is, I know that the council house is full of councillors, but it's not only for us. Large members of the public use the place as well. And they too might have need of one of these, so I think it's a good idea.
Thank you, Councillor Tui. Thank you, Ruth, for your update. Really appreciate it. So there's some recommendations from put forward from this committee. So we recommend to the Cabinet Member for Health and Adult Social Services that Plymouth City Council commissioned defibrillators at the local locations identified, which includes the Guildhall. Recommend to the Plymouth Health and Wellbeing Board that PCC works with partners to promote Restart a Heart Day, which takes place on and around the 16th of October each year. That PCC works with partners to promote CPR training. That all defibrillator owners across Plymouth are encouraged to register their defibrillators on the circuit, which is the National Defibrillator Network. That all defibrillators owners across Plymouth suitable for public access should consider whether access should be widened to 24/7 if not already. That PCC promotes schemes to access funding for publicly accessible defibrillators amongst communities. And the last one, that PCC work with partners to provide defibrillators at St Bruno Library and Southway Library. We'll go to the vote. Everybody in favour? Thank you all very, very much, and thank you, Councillor Beer, for bringing this motion.
Thank you very much indeed. Thank you, Chair.
Thank you. We're now going to go to tracking decisions. Elliot?
Yes, thank you, Chair. As members will see in front of them, we've got quite a hefty page of tracking decisions, 34 to be exact. What I've tried to do with these is to put small responses in the main tracking decision log, and those that require sort of a more detailed explanation, they're from page 135 in your packs onwards. I've separated them out. This is quite an ongoing piece of work, really, although replies have been received to quite a lot of them. I think a meeting with the chair and Anna and others to go through and make sure that while we got a reply, they're actually followed up on and that they meet what we were asking. Also, to make the committee aware, I've received most, if not all, of the ICB's recommendations, which are marked in progress on your sheet. That happened subsequent to the agenda being published, so I'll circulate them to you all. And lastly, had a response from Liverpool South West that they'd, in response to our veterans recommendation, like to come to the Armed Forces Covenant and get more involved to become veteran aware. So an ongoing piece of work there. I think that's all I'll say for now. Thank you, Chair.
Thank you very much. Any questions? Councillor Noble.
Lots of these are from our mental health select committee. So just think that there was quite an important day there. Lots of the things that we've heard about today, there was the elements, the mental health elements of those. So these are quite important. Good to see that some of them have there's some progress or at least more information. You know, that was only a few months ago when we did that. It's good to see.
Thank you, Councillor Noble. Anybody else? Noted. And the last bit, it's been a bit of a long meeting, is the work programme. So is there anything that the members themselves, any of you, would like to bring to the work programme? I have had a meeting with Ross and Elliot and can't remember who else, Anna, there was a few items that I would like to bring in. So I would like to know about occupational therapists, the care homes, or social workers. There was quite a few bits, wasn't there? So is there anything that members themselves would like to bring to? Oh, you, Ross, sorry.
Through you, Chair, you've just agreed a couple of things this afternoon concerning recommendations from the local government ombudsman, and there was a request earlier from Councillor Ricketts for some more information around procurement, around dom care, and etc. So I think working with Gary and Anna, we'll get a report put together and give you an idea of when that might come.
Councillor Riley.
It might not be. It's just that when the guy was talking in finance, there was a shortfall for homelessness or something. I just wondered if we could perhaps hear a bit more about that, or is that another scrutiny?
Yeah, through you, Chair. That one does sit with performance scrutiny committee, but obviously as it's the same department, there's a little transfer across in terms of funding. So, but it is a performance scrutiny issue.
I thought so. I thought I'd ask. Thank you.
Okay. Councillor Watkin.
I can't see anything on here for the update on what's going on at Derriford. Presumably that needs to come to a future committee as well.
Through you, Chair. I mean, updating in reference to the build out of the So we'll get that added on as a regular. I mean, I think it will depend on the speed that they're actually able to go. Thanks, Chair. Oh, through you, Chair. Obviously, councillors can make suggestions at any point. We're always happy to receive them. And there is functionality on the members' hub to just submit a quick form to allow you to put forward an issue for scrutiny.
I'd just like to thank you all for being here today. It's a bit longer than what we thought it was going to be, to be fair. But hey, that's good, because that means that people were asking questions. So I'd like to thank you all for turning up today. Thank you, Councillor Aspinall, for being here, and you, Ross, Elliot and Gary.